have this event, which is prepared by ALIBIRA and also Birra Foundation. Really, I am grateful to be here and to participate in this event. Again, I will say to all of you, happy World Mental Health Day.
I would like to appreciate Oromia Health Bureau for initiating this wonderful international conference. Probably Oromia Health Bureau is the only regional health bureau who ever has prepared such an event. Thank you very much for that.
Dr. Tesfaye, Deputy Heads, Dr. Tesfaye, Dr. Tigis, Dr. Malcamo, all protocol observed. Akan jirtan, bagarabin at sinugay. Oromia Health Bureau, we cannot thank you enough for taking ALIBIRA Foundation, a very small, or a baby organization, under your wings. I truly believe that the sky is the limit going forward.
በማምጣት በተለይ በኦሮሚያ ክልል ላይ በጣም ከዚህ ፕሮዳክት ለመጀመሪያ እዚህ ጋር የምታዩት የቬንቲሌተር ማሽን ያለው ለአዳልትም ለቬንቲሌሽንም የሚሆን ነው። ከዚህ ቀጥሎ የምታዩት ደግሞ ክሊያ ወይ ደግሞ ሆርሞን ያለው የብለድ ካልቸር እና የማይክሮባዮሎጂ አጠቃላይ የአይዲሲቲ ወይ ደግሞ ድረግ ሰሰብሊቲ ማሽን የምንለውን ለእናንተ ይዞ መጥቷል። ይሄኛውም በተለያዩ ሆስፒታሎች ውስጥ አለ። በተለይ አዳማ ሪጅናል ላብ ይሄን በስፋት የተጠቀመበት ያለ ነው። ከዛ ውጭም ደግሞ ያለ እዚህ ጋር የምትመለከቱት ኤም680 ብዙ ሶሉሽኖችን ይዞ ይመጣ ወይ ደግሞ ኢንቴግሬትድ ሲስተም የሚባል የተለያዩ ቴስቶችን በአንድ ላይ ኮምባይን አድርጎ በመስራት ያለ ማሽን ነው። ይህ ማሽን የሚሰራው ትልቅ ካፓሲቲ ያለው ነው። ክሊኒካል ኬሚስትሪ ቴስቶችን ኤሌክትሮላይት እና አሚኖ አሲድ አንድ ላይ በማለት ወደ በሰዓት በጣም ትልቅ ስርቆት ያለው ቴስት እየሰራ ያለ ማሽን ነው እና ይህም ወደ 4 ኦስኤች ፋሲሊቲዎች ውስጥ እንደነ ቢሾፍቱ መልቱ እና ሻሸመኔ ሆስፒታል ላይ ገብቶ ስራ እየጀመረ ያለ ነው። ይሄ በትልቅ ማሽን ነው። ወደ 3 በአንድ ሳምፕል 3 ቴስቶችን መስራት የሚችል ወይ ደግሞ ክሊኒካል ኬሚስትሪ በጣም ብዙ ቴስት ሞዳል በአጭር ሰዓት ውስጥ በሾርት ታይም ኦፍ አወር የሚያወጣልን ማሽን ነው እና እንደዚህ የመሳሰሉ ማሽኖችን ይዞላችሁ መጥቷል። እነዚህ ጊላንዶ ከእናንተ ጋር በስፋት መስራት የሚፈልግ ድርጅት ነው። ሲመሰረትም የጤና ተቋማትን ችግር ለመፍታት እናንተ ጋር ያለውንም ችግር ለመፍታት የተቋቋመ ድርጅት ስለሆነ እንኳን ሰላም መጣችሁ። ላላችሁ ችግር ከሆነ አፍተር ሴል ሰርቪስ ከሆነ ኮንታክት ታደርጉ ስላላችሁ ከ40 በላይ የአሜሪካ ሰራተኞች አሉ። ከአይቢዲ ለሁሉም ፕሮዳክቶች መፍትሄ ለማምጣት ነው እዚህ ኢትዮጵያ ላይ ድርጅት እየሰራ ያለው እና ስለዚህ አሁን እንስራ ለማለት ነው።
that available resources that can be leveraged to the recovery or care of people with serious psychosis. So we know the treatment gap for mental illness is very large. Even those who come to the healthcare refractory cases, specifically for schizophrenia, is 30%. So where are these people? Where are the resources that can be leveraged to recovery-oriented care of these people? We try to search and see at least the selected area of Addis Ababa within 2 subsidies, Kirkos and Lidera subsidy. So we found many types of social and institutional organizations. The first one is we found 124 health fractional health, certain religious organization, 104 non-governmental organizations or chartered organizations. So this all, and also from the social organization we found we didn't work still now in Ethiopia, specifically in Addis Ababa, is an important social organization that currently people are getting help, at least the social help that are seeking from this organization. So we tried to map the distribution of these resources, but because of the reform of Addis Ababa subsidy to locate, but roughly we put this to this distribution of the resources. So we are saying that there are many resources that can be liberated to the recovery-oriented care of people with severe mental disorders. So in my opinion, thank you.
My name is Mr. I am a PhD fellow in sciences. The title is Effectiveness of Text Messaging for Reducing Substance Use. As a background, we know that substance use is a major public health problem, especially for users, and it's highly related with risky sexual behavior, mental health issues, risky violence, and other related issues. Even though the problem is higher in users, we usually use traditional kind of treatment, a one-to-one kind of way of solving problems. So that's not effective because it has a limitation in reaching and acceptability by users. So we also have see that SMS or text messaging is effective in risky behavior and improving preventive health care, promoting chronic illness self-management. So we start having at that time questioning ourselves as to review whether this text messaging is effective for users or not. So based on this question, we try to address, to answer this question by using these methods. We search in detail with these databases. So we found finally as effective for text messaging for users. And also we subgroup those who follow for 3 months and those who follow for more than 3 months. Those who follow for 3 months is more important than that of more than 3 months, because if the message is more intensive and timing and more frequent. It's more important than that of following the patients more than 3 months. Within that, we finally conclude that this text messaging is effective for users. If you have any question.
Thank you, Mr. for your nice presentation. Then we continue to hear. So, President Brad will present his finding.
Okay, thank you. I'm Brahma. I'm currently a PhD student at Addis Ababa University under the Department of Psychiatry. And my research area is abortion and mental health disorders. So we know that abortion is a procedure that is introduced recently as a procedure of maternal care. So it's not abortion that's causing depression or anxiety or mental disorder, but it is the factor that is related with psychosocial effects that could have a disorder. Therefore, this is the baseline data for the META project, and we have found that almost around 18.2% of women suffer from mental distresses. Therefore, there are certain factors that is highly related or acting as a risk factor, and from these factors, cohabitation, being unemployed, having less support, and stigma and discrimination, use of substance are highly related with that of mental disorders, their abortion. So the next project is to scale up this project to comparative stage or comparative study, and this comparative study will include those who undergo abortion and those who did not receive abortion. And what is the experience or life experience of this project? How do they experience mental disorders? Would be another objective. And the second one is just what does mental disorder mean for healthcare providers providing services, especially abortion services? And this is a project right now. Therefore, this is simply a baseline data. It's first in Ethiopia in abortion related disorders. So what we are going to recommend is we have to integrate the services, especially mental health services, in any other clinical areas, especially in maternal and child areas, because they suffer a lot. They suffer from the psychosocial point of view, so that they should have to have certain counselings that could address. I have seen the ministry guidelines that is serving as abortion guideline, and I found only one term that is speaking about mental health. It says mental and physical. It's a single one, a single term. Therefore, we have to address this point. It's a neglected area. Abortion by itself is neglected, and mental disorder is another, so that we have to address this at a large scale. Thank you very much.
Thank you.
Hello. So I'm Addis Ababa. I'm came from Birra University. I have a topic on the research title: Persistent mental health challenge, prediction, and understanding risk factors among adult population in Ethiopia. As you know, adult population face common mental health problem across the world. Globally, nearly 300 million people suffer from mental health problem, of which nearly more than 80% of the mental health problem occur in low resource setting. For instance, in Ethiopia, 5% of the people struggle with mental health problem. Individual with untreated mental health challenge will increase the odds of illness, the chance to develop more illness. They become isolated person. They also become a societal addiction, and they are vulnerable for death. Therefore, this study aims to leverage machine learning algorithms specifically to predict the existing persistent mental health challenge, the frequency, how much the adult population faces for mental health problem, and to use the algorithms to identify and understand the risk factor for this persistent challenge, specifically for adult populations. Therefore, the data source for this study is found from World Health Organization and Communicable Disease Resource. As you know, we do have rich and very important secondary data, which is not yet well analyzed, but they are very important for policymakers and for healthcare practitioners. Therefore, I have accessed the data from NCD and communicable disease data repository sites. I hope which is collected by Ethiopian Public Health Institute. And the total 9,923 samples are used. Then for this data, 9 algorithms are considered to develop, validate each algorithms to understand their prediction abilities or capabilities, performance using this data. Then before doing this, we set the data into, we have partitioned the data into training, testing data. For testing data, we use 80% from this total sample and 20% from this total sample for testing the performance of each algorithm. Then for, many algorithms are not, maybe unless we perform hyperparameter tuning for increasing their performance, specifically to reduce the false positive and false negative rate. Therefore, tenfold cross-validation was used to enhance model performance. Different performance evaluation matrices, like true positive, false positive, including ROCAL used to evaluate the algorithm's performance. Again, a heat map was used for correlation detection and management, because this figure indicates that the correlation is significantly with another variable. That means they have the same effect. Therefore, we can either remove either of one, because they have the same power on the prediction or the effect on the problem, the persistent mental health. Therefore, we use the heat map and future predictor. And after identifying, we need to order or stratify which factor is the top predictor for persistent mental health challenge. Therefore, we have used the future importance score. Based on the result, there are before data management, I remember in the main document nearly 24, but performing different data management process, nearly 39% of the adult population face persistent mental health challenge. There is a gap, there is a difference between Ethiopia Public Health report on NCD website and this finding. This is because due to data management have a significant impact on data processing analysis. Because I have removed some missing values, and additionally I have considered the adult population aged more than 18 years. Based on our performance evaluation, XGBoost algorithm is the best model, which is visible in this with area under local value of 79.8 score. It is the best understand the risk factors. Okay. Therefore, based on our prediction model, the prediction model shows that from this algorithm, almost 80% of the adult population are predicted to or classified to have a persistent mental health challenge. So what? Policymakers, before this problem is happen, they work on the adult population because the algorithm indicates that majority, nearly 80 of us are going to develop persistent mental health challenge unless proactive action is taken. Then again, the risk factor, age, the first one is based on our future important score, age, marital status, work status, family size, time spent at school is or education. The top 5 important predictor for the persistent mental health challenges among adult population in Ethiopia. Therefore, what I recommend for the majority of the adult population as we see is developing or facing persistent mental health challenge. Different predictors are identified, stratified, then tailored and context specific for mental health intervention is very important. Very important. So thank you. This is my short.
Thank you. Decided for your yeroo boqonnaa shayii gaaffii sidiin galee gaafachuu dandeessu nalbaata warri mindirees galanii jiru warri poster presentationis yeroo boqonnaa shayii asii waan ta'eef kan gaaffii sidiin ta'u gaafachuu dandeessu. Thank you.
Yes.
Akkam bultan sagantaa keenya yoo daa'imman kan darbamaa jiruuf I think sagantaa keenya jalqabna. So I want to say good morning again. So we have to start our 2 days program. This is the second panel discussions. So I kindly invite our
Ethiopia. So as a person practicing in mental health professional as well as representing mental health professional, I'm really happy and I would like to appreciate agents behind this event, Ethiopia Health Bureau, ALIBIRA Foundation and others. So thank you very much. Saying this, I would like to welcome my panelists. I would like to welcome my panelist. The first panelist is Professor Alaka Amakazala. He is currently a professor of mental health epidemiology and public health at the University of Gordon. He has about more than 20 years teaching as well as research in the community service, leadership experiences, as well as a reviewer and editor of national and international journals, and he has more than 100 research articles. I would like to welcome again Dr. Birra is a 6-year resident of at the University of Minnesota, USA, with a strong clinical and academic foundations of neuroscience. He has cultivated extensive research experience and computational neuroscience and neuroimaging, neuroecology, as well as is contributing to the innovation of innovative approaches of brain, tumor, diagnostic and surgical approaches. So, driven by both technical excellence and passionate care, the prize represents a new generation of neurosurgeons and surgeons dedicated to pushing boundaries of pediatric brain health. So, mainly this topic is called mental health from inside to out, in respective to neuro. I will come again Dr. Lulu Bakara, who is a distinguished psychiatrist at Emmanuel Mental Specialist Hospital, with more than 14 years of clinical research leadership experiences, and at the level of different from starting as a department head, research and training director, as well as clinical director of Annual Mental Specialist Hospital, and then there is also national mental health trainer. Next, I will welcome Sister Agitu, mental health specialist from Ministry of Health Mental Health Desk. Sister Agitu have experience of more than 20 years, clinical, academic, as well as research activities at Annual Mental Health Specialist Hospital, and currently working at Ministry of Health as a senior expert of National Mental Health Program, and also actively involving in shaping national mental health strategy, clinical policy, as well as coordinating different development of national guideline and training manuals. So she also working on the promotion and advocacy of mental health, as well as integration of mental health regulation of national nation. Next, I will come Mr. Zagaye Yohannes. He's an experienced senior mental health specialist with experience more than 15 years in clinical, academic, as well as leadership. Currently, he is president of Ethiopia Mental Health Professionals Association, and also he is a board member of Ethiopian Professional Association Alliance, research and training director currently at Emmanuel Mental Specialist Hospital, and they contributed more than 15 publications at national and international journals. Saying this, so now we'll start our panel discussion, and to directly proceed to our place or to this session, panel discussion, which is continuation of our yesterday panel discussion. The subtheme for this panel discussion is considering mental health training, research and policies perspective of Ethiopia, learning from the past and framing for the future. So I will have some specific questions for this particular subject inputs from my panelists. So the first point will be addressed by Sister Agitu, which is mainly related to the progress in the current state of mental health training in Ethiopia. So I will give a chance to Sister Agitu to address you in this area for 5 minutes, please.
Thank you. I would like to say Happy World Mental Health Day for all of you. Today is the day on which we are celebrating mental health. Mental Health Day worldwide. My colleagues are celebrating this day in other places. I am honored to be here to have this event, which is prepared by Oromia Kings Bureau and also ALIBIRA Foundation. Really, I am grateful to be here and to participate in this event. Again, I will say to all of you, Happy World Mental Health Day. Okay, this is great. We are again some kabajula. While again some more Ufa, Imamati, Hundumati. We are Kunega, we are Dati, Malifi, we are to wine again some Akabiyolis sat, Akabiya the Hundumat, the Alatamura, Kaderol, the Guayana. Thank you. I will go to my points, which I am just to present. What is the progress and state of mental health training? This topic goes beyond 40 years in Ethiopia, where it is started in Amamil Hospital for more than 40 years back in diploma psychiatry. As we know, formerly Amamil Hospital is addressing the mental health issues in the country regarding training, supervision and everything. At that time, diploma psychiatry nursing or advanced diploma is started as an Ethiopian calendar in 1979, which goes for around 20 years, and also produced around 450 psychiatric nurses which were working on the regions and other health facilities. Again, when we come back to another progress, around 2001, Ethiopian calendar on the University of Mekelle University started to give psychiatric nursing under PSC. So they started again master's program is started in integrated clinical and community mental health jointly with Aman Hospital at Golden University. This is the progress and is a good progress. Almost around 10 to 12 universities give PSC psychiatry in our country. The other is when we come to the residency in Ethiopia, residency started around 1994 in Ethiopian calendar. Before that, the specialty, the residency is given abroad. Currently, Ethiopia do have almost 5 universities giving residency for medical areas. So we do have around 165 to 180 psychiatrists in our country. In this case, we do have only specialists working in child, only 4 for our country, 1 addiction psychiatrist, only 1 forensic psychiatrist, but we do not have other specialties in psychiatry area. This is the training which is given. We are seeing a lot of progress of the training setup. When we come to the Ministry of Health, we do have training is under mental health program, which is given for health professionals. The one is integration of mental health into primary health care unit to access the services into the health centers and other health facilities. This is the WHO training manual which we are using, the MHGAP-IG, or the mental health gap action program to integrate mental health service into primary health care units, which is developed for developing countries. We are giving training for all regions. We coordinating with regional health bureaus. The other is refresher training courses we do have. Currently, we do have around 5 materials prepared in the Ministry of Health, especially for mental health professionals. The one is the neurological aspect regarding substance use treatment for psychological intervention and mental health. Oromia Health Bureau is just launched and just is working on this, give this refresher training for around 90 health professionals working in Oromia setup. I would like to thank Oromia Health Bureau. They are the pioneers to use this material. The other is we integrate, currently we are working on the integration of mental health into diseases. Currently we are working with the integration of mental health with HIV care. The other is we are providing other training for integration of mental health and psychosocial support with cancer care. Again, we are just working on integration of mental health with TB treatment. Some of the trainings which I will have to update are these. Thank you.
Okay, thank you, Sister Agatha, for addressing very important points, especially the training on mental health area from the past, which is a lack of a drop, started as from the global level, and later specialists have also started. Nowadays, we have BSc in addition, master's program in addition, as well for the last 10 years, where there wasn't been in-service training for mental health professionals, whether BSc, masters, or specialties. But with the work of Minister of Health Mental Health Desk, refresher training or research training manuals were prepared. Oromia Regional Health Bureau the first two inaugurating the start refresher training. After graduates are like practicing without training for the last 10 years, but Oromia Health Bureau started last year. Thanks to Oromia Regional Health Bureau, NC is especially. So saying this, I proceed to the next point of discussion, which is mental health research in Ethiopia, past, present, and the future. This point will be addressed by Professor Talaka. Please, Professor Talaka.
Good morning, everybody. Thank you very much. I would like to appreciate Oromia Health Bureau for initiating this wonderful international conference. Probably Oromia Health Bureau is the only regional health bureau who ever has prepared such an event. Thank you very much for that. Saying this, I would like to briefly talk about the research developments in mental health in Ethiopia. Training, research, and policy are inseparable. One influences the other. Of course, training provides with the knowledge and a skill of conducting research, generating evidence to influence policy, enhance mental health service, provide quality and equity mental health service. So the advancement of research in mental health has been burgeoning with the expansion of mental health training. The earliest research in mental health were limited to institutions and were only prevalence studies and were mainly conducted by foreign experts, scholars. And since the mid-1980s, after the commencement of training of psychiatrists, and in the early 20s, after the commencement of the training of master's level mental health professionals, that most of the researches are being conducted now because the training of master's level mental health professional requires them to conduct research on mental health topics, and we can classify the research in Ethiopia as first level, second level, third level, depending on the rigor, the coverage of the research. The earliest researches were mainly cross-sectional and in institutions, and later on some more rigorous researches such as longitudinal cohort studies, and now experimental studies are being conducted in Ethiopia. There is no nationally representative research about the prevalence of most of the psychiatric disorders. However, today there are more than 700,000 publications in Ethiopia on mental health topics, and therefore now researchers are producing rigorous research outcomes to influence mental health policy and improve mental health quality and equity. And therefore, research is now burgeoning, and there are hundreds of publications, journals on mental health topics, and most of them are on very few mental health topics. Probably more than half of them are on depression and comorbidities with depression, such as depression in patients with medical conditions such as HIV, chronic non-communicable diseases. But research is limited, especially on adolescent mental health, child mental health, and substance-related disorders. Most of the research on substance-related disorders are simply frequencies, proportions, and there are no rigorous research undertakings on most of the mental health problems, because we have more than 300 psychiatric disorders with their specifiers. Probably they may be more than 600, and research is limited only on very few, especially mental health disorders that are known priority mental health disorders according to the World Health Organization, such as depressive disorders, which has about 16 variants with their specifiers, including peripartum depression, antenatal and postnatal depression, anxiety disorders, psychotic disorders, mainly schizophrenia, spectrum disorders, and substance disorders, mainly alcohol use disorders, not actually the use disorders, but usually research is on the frequency or the prevalence of alcohol use. There are no many research on the use disorders, and the screening tools that are used for mental health research usually were developed in the Western countries, and most of them require validation, cultural adaptation. However, we use most of them as there, and I don't think they actually measure what is happening on the ground. And today there is a need to validate those tools, and we are pressurizing PhD students, because we have trainings on PhD in mental health epidemiology in Addis Ababa University and University of Gondar, and we require our PhD students to validate screening tools, because there are about 1,800 screening tools to measure mental health disorders. If you pick only screening tools for depression, there are more than 15 screening tools, and we don't know which tool is the most appropriate for measuring psychiatric disorders in our setting. So we need to validate screening tools, and we push our PhD students to validate these tools before they use to measure psychiatric problems. This is what I can say about the development of research.
Thank you, Professor. Thank you, Professor, for your points on research in Ethiopia related to mental health, past, present, and future context. I hope researchers and professionals get a critical point on here, especially on the limitation raised. again, I'll go to next point, which is again addressed by Professor Talaka. What mental health epidemiology in Ethiopia looks like, and regarding the risk factors and the consequences for related to recovery. Thank you.
Thanks very much once again. So concerning the epidemiology of mental health disorders, when we talk about epidemiology of mental health disorders, we are referring to the occurrence, frequency, distribution, and determinants of more than 300 psychiatric disorders. And this epidemiology varies according to different characteristics of people. Each psychiatric disorder and its epidemiology varies according to age. Some psychiatric disorders are more prevalent in a certain age group. For example, if you take schizophrenia, it mainly affects the productive population. The young population, 15 to 24 years of age, and about 50% of schizophrenia have their onset below 20 years of age. And there are some psychiatric disorders that are more common in children. Other psychiatric disorders are more common in the elderly, for example, neurocognitive disorders, neurodevelopmental disorders, such as the autism spectrum disorder, intellectual disabilities, attention deficit hyperactivity disorders, and other disruptive and behavioral disorders occur in children. And there are also variations in sex. Most of the psychiatric disorders affect females more than males, unfortunately, probably because females carry more responsibilities in caring for family, and they may be exposed to several risk factors that are related to pregnancy and childbirth, hormonal fluctuations, and several burdens such as domestic violence and intimate partner violence. As a result, most of the psychiatric disorders are more prevalent in females than in males. You take, for example, depression is twice or more common in females than males. There are also some psychiatric disorders that occur only in females. For example, premenstrual dysphoria disorder, postpartum depression, antenatal depression, they can occur in males definitely. And some disorders affect men and women equally. For example, schizophrenia. The prevalence of schizophrenia is estimated to be about 1%, and it affects men and female equally. And the disorders with highest prevalence are depressive disorders and anxiety disorders, estimated to be affecting about 15 to 20% of the population. And globally, it is estimated that 1 in 7 people are affected by a mental health condition, and a total of 1.1 billion people is estimated to live with a certain mental disorder today. And there are disorders known as priority mental disorders by the World Health Organization. These are priority because of their high prevalence, because of their capacity to lead to disability, and because they are severe. Some of them require long-term treatment. And these priority mental health disorders include depressive disorders that affects about 20% of women and about 20% of men. Psychotic disorders or mainly schizophrenia, schizoid disorder, about 1%, and usually occurs among young people and more in urban than in rural settings. I mean, they are more common in urban than in rural settings. Then they are more common among the poor people, uneducated people, and those who are exposed to stressful situations and childhood adverse experiences. And the other primary mental disorders are bipolar disorders. Bipolar disorder also affects about 1.5% of the total population, and these are slightly higher among men, and they usually occur in mid-20s to 40s. Others are anxiety disorders. They are also very common disorders, probably next to depressive disorders. Of course, depressive disorders and anxiety disorders are very highly correlated, occurring about in 90% of patients with or persons with anxiety disorders also might have depressive disorder. The other priority disorders are neurocognitive disorders, especially dementia, and childhood disorders, mainly autism spectrum disorders, and intellectual disabilities, attention deficit hyperactivity disorder, and substance-related disorders. Epilepsy is also not psychiatric disorder included under the priority disorders, for which the WHO is recommending to be integrated with primary health care, and these disorders are very common. However, we don't have a nationally representative data on the prevalence of each of the psychiatric disorders. I think this is what I can say about the tumors. Thank you very much.
Yeah, thank you, Professor Talaka, for addressing the condition of mental health in Ethiopia, respective to risk factors and consequences. The next area.
Sorry, I didn't address the risk factors. Shall I say?
Yeah. 2 minutes.
Sorry, I skipped the risk factors and the consequences of mental health disorders. So generally, the risk factors of mental health disorders are said to be the biopsychosocial and spiritual model, as well as environmental factors. So there are biological factors, including family history of mental illness, genetic abnormalities, biological factors including neurotransmitters, hormonal imbalance deficiencies or excesses, and psychosocial factors such as losses, any stressful events and situations. This can be natural disasters or man-made catastrophes. When it comes to Ethiopia, mainly the man-made disasters are more prevalent than the natural disasters. Fortunately, we don't have the natural disasters that are very rampant in the developed world, such as earthquake, floods, and tornadoes, and wildfires are not very common in Ethiopia, but the human-made catastrophes are very common. Conflicts, war, armed conflict are very common, and these are among the psychosocial and environmental factors that contribute to mental health problems. The consequences of mental health disorders are very rampant. Many of the psychiatric disorders may lead to suicide. This is one of the consequences of untreated psychiatric disorders. If you take depression, about 15 to 25% of persons with depression may commit suicide, and about 10% of people with schizophrenia and substance-related disorders may commit suicide. This is one very major consequence of untreated psychiatric disorders. The other consequence of psychiatric disorders is exposure to other medical conditions, exposure to substance use disorder on top of a mental health disorder, and many psychiatric disorders lead to disability, for example, schizophrenia. Disability as a result of the disorder itself, and disability may also result from the side effect of antipsychotic medications, unfortunately, and maybe a permanent disability. This loss of productivity, not just limited to the individual, but also to the family caring to the patient, also to the healthcare system, and to the government as well. There is loss of productivity, and disability life years are very common as a result of psychiatric disorders, and persons with psychiatric disorders are likely to die 10 to 12 years earlier than the general population. That means life expectancy of persons with psychiatric disorders is shorter than life expectancy of the normal people. So it reduces life expectancy, and many destructions. Some persons may be dead, dangerous actually, not all persons, but some may also commit homicide in addition to suicide. And these are some of the consequences of untreated psychiatric disorders.
Okay, thank you, Professor, for addressing very critical issues. Now, the point of our discussion is how we explain the current mental health policy perspectives, and that is translational and practice at the national, at the regional, and as well as lower level of practice. So this area will be addressed by Sister Akitu. So, Sister.
Thank you. Currently, we do have a national mental health strategy, which is this year is the final year, because it is from 2020 to 2025. We do have priority areas on our national mental health strategic plan. Priority area 1 shows governance, leadership, coordination, collaboration, and partnership. And these areas, the progress is endorsed by Ministry of Health. It is integrated into the HCTP2 or Health Strategic Transformation Plan 2, recognized in National Emergency Response Framework. Partnership have been established with non-governmental organizations and other governmental organizations. Where we see in this area, the gaps are weak institutional cooperation between other sectors like education, social protection, other organizations, because coordination, collaboration is needed in every sector to achieve the goal. This is the gap. The other is absence of dedicated budget regarding mental health within regional health bureaus, zonal and wellness health. This is the gap. Also, inadequate or integration to access the services of the gaps which we do have with the governance, leadership, coordination, collaboration areas. On the priority area 2, development of adequate and competent human resources. This is ongoing. We do have human resources in some of the aspects, but We didn't cover all the health facilities in our country with mental health professionals and trained manpower. But the progress is good. We do have around 480 basis laboratories, nurses working in local areas, image gap training given for around 1,600 non-mental health professionals for task shifting to assess, screen, manage, and refer mental health conditions. Growing involvement of health extension workers is there to identify the community level mental health problems at home level, but it is still inadequate to reach out others. On the promotion and the prevention of mental health issues, we are working on the advocacy of mental health areas, national awareness campaigns. Like this month, October month, we are working on advocacy through mass media, through gatherings and panel discussions. This can help to reduce stigma and to promote mental health. This is the other aspect. Also, we are working to integrate into the community on the promotion activities with religious leaders and community leaders. Still, stigma is there in the community, so this is our priority area in which we are working. Also, it needs scale up and working on the advocacy and also the awareness creation campaigns in schools, in communities, and in other gatherings. It also needs focus to do on that. The other is priority area 4, integrating clinical service. This also needs more to do on that, but we are working on this. In Ethiopia, we do have around 353 hospitals, 3,700 health centers, and also 17,000 health posts. But the coverage of mental health service, when we see only 70% of our hospitals are giving mental health service in outpatient and inpatient level, using psychiatric professionals. We do have only around 600 health centers giving mental health service, so image gap trained and psychiatric professionals and other psychiatric professionals. So the gap is there. So low treatment coverage is our gap. Sometimes there are interruption of antipsychotic medication in our health facilities. Limited service for children and adolescents regarding mental health is our major gap. People with disabilities and homeless mental patients, those who are homeless and have severe mental health problems are not addressed. So this is our gap regarding the service. The other priority area is our research and surveillance, monitoring and evaluation. In this aspect, we do not have a nationally representative data regarding mental health problems for each of the disorders. This is the gap, and we call for the researchers to do and to engage on the national mental health related researches. The other is monitoring and evaluation is ongoing, but it is not enough when we see there is still gap in budgets and the resources, and we need for more collaboration and working together. Thank you.
Okay, thank you, actually, for addressing the important issues regarding the translation of policy to the practice. Actually, I will be back to you, and I will say something on the integration versus the unemployment of psychiatric professionals. Integration through image gap training is a WHO program, which was really effective for developing countries, and our countries also really implementing and gave some benefit from it. And then when we see on the other side, psychiatric professionals in psychiatry are being unemployed, we will come to that. We are going to say on some on that after we hear from the next panelists regarding the number as well as the role of professional association. So as we know, in Ethiopia we do have professional associations working on mental health related, representing the professionals: Ethiopian Mental Health Professionals Association, Ethiopian Psychiatrists Association, Ethiopian Psychologists Association, plus Ethiopian Social Workers Association. These all are partners working, supporting, contributing by collaborating with the Ministry of Health and other regional health bureaus. So now I have a point to be addressed by Mr. Zakaria, which is the role of professional associations in bridging the research as well as the practices. So the integration also the bridging the gaps, so research as well as practice. What is the role of health professionals? So this is time for Mr. Zakaria, please.
Thank you. I would like to thank Oromia Health Bureau and ALIBIRA Foundation for giving this chance to represent professional associations and mental health. Saying this, as Dr. Adam mentioned, we have around 5 different professional associations who are linked with mental health: Ethiopian Psychiatrists Association, Ethiopian Mental Health Association that I represent, and Ethiopian Psychologists Association, Ethiopian Social Work Associations. These are professional associations mainly focusing on mental health areas. However, there are so many difficulties, as you all know. I hope you are also in one or another way member of professional association. So you know the challenges and the limitations of professional associations. So Ethiopian Mental Health Association is a professional association, mainly includes mental health master's graduates and undergraduate psychiatric nurses. And we have recently around 1,200 members, and around 500 of them are active members. So professional associations are a significant role in mental health services, research, as well as training. Where just to mention some of the gaps, as for my perspective, there are significant gaps on training and also research areas as well as service. So what are the gaps related with training? So the first one is both in-service training as well as pre-service training. We believe that there are gaps on the curriculum, gaps in the way they provide training, especially some of the cultural aspects and community-based service aspects may not be mainly included in the curriculum. So the associations are working including our association, working on the curriculum revisions, and we are actively working with universities. As mentioned before, psychiatric trainings are the number of universities increased in the last 10 years from 2 to 3 universities to around 15 universities currently. So is growing. However, we are still working on the curriculum issues related with gaps and the curriculums. The other one is service. As mentioned previously, there are limited access to mental health service still, as we compare to the total health service coverage of Ethiopia, and the mental health service provided in these health facilities. Still, we should work more. Even though through time, the service coverage is increasing due to increased number of professionals, mental health professionals, as well as non-mental health specialists who are trained on MH gap. And we are still also providing trainings, especially for non-mental health professionals through our associations. So we are actively engaged in providing training through our members. We work actively with Ministry of Health as well as Oromia Health Bureau. I would like to thank Oromia Health Bureau and CDDs for giving the chance. We try to train hundreds of professionals on MH gap. And the other one is the gaps, research related gap. There are limited research activities locally, especially producing locally relevant data. So the capacity of the research, when you see the mental health research, even though it's growing, still we believe that more should be there. And as previously mentioned, we don't have national representative data. We don't have the mental health research is not included in the national surveys. So we are pushing to include at least the most common prioritized mental health problems in the national surveys. And the other one is there is also low priority of funding and also budget allocated for mental health research. So we are also advocating to fund, to consider mental health during funding for research. So professional associations have, when you see the whole number of professionals in our country, as previously mentioned, we have around 180 psychiatrists and we have around 516 mental health specialists who are master's level graduates. They are taking the lion's share in the providing services in the country because they are working almost in all regions, and also they provide training in universities for students, for undergraduate students. And also we have recently around 2,377 psychiatric nurses who are trained in the last almost 15 years. So the training was started by Amami Hospital. As you all know, Amami Medical Specialized Hospital is the biggest and the only specialized center, the referral center for the country. And we started, I'm also working in Amami Hospital, so we started the master's program as well as the undergraduate program in collaboration with University of Gondar and Mekane University. And later on also Juma University started MSc program myself. So this MSc program mainly started due to shortage of specialists in our country. As you all know, we have few specialists, even though the number of specialists also growing through time. Even though most of them are still working in urban cities, including us. So the mental health coverage in regional and in areas, in zonal areas, are mainly covered by MSc and BSc psychiatry professionals. So we, as a mental health professional association, we encourage to coordinate research, training, as well as service provision to high quality for patient who needs mental health services. So the professional association have significant role in bridging the gaps And we are recently working closely with Ministry of Health, Ministry of Education, and also Oromia Health Bureau and other health bureaus in the country. Thank you.
Thank you, Mr. Zagay, for addressing the issue of especially the role of professional associations and mental health services in bridging the gaps. And now the time is to discuss on the role of innovation in mental health service, because we are in the era of digitalization and innovation. So what's the role of innovation to the mental health regarding the diagnosis, care and services? So this area will be addressed by two of my panelists, Dr. Lulu and again Dr. Birra. So I will give a chance to Dr. Lulu first.
Thank you. I would like to thank Oromia Hotel and ALIBIRA Foundation for giving me this chance. As you know, I'm working in Mani Mental Hospital, and Mani Hospital is the largest hospital. We provide in a year we treat about 138,000 patients, and these patients are patients with severe mental illness. Innovations for us is to improve quality and to increase access. Concerning quality, we are trying to integrate medical service along with mental service, because as you know, most of mental ill patients have medical illness. Research says that more than mental ill patients are 7 times more susceptible to develop medical illness. So, ignoring medical illness in mental ill patient is not right. It is not a way of giving quality service. So, especially in the last 2-3 years, we are integrating medical service to our service. And every patient who came to a medical hospital, currently I'm working at the emergency department, I'm the head of the emergency department. Every patient who presents with medical illness, we evaluate him for physical illness. We have GPs, internists, and he will be evaluated for any medical illness. Okay? So he can talk about medical illness. We know that mental ill patients, most of them have a problem to say they have this type of illness or this type of symptoms. So we do physical examination, laboratory examinations for every patient that presents to our hospital. And I think this is the best way of approaching mental ill patients. Mental ill patients are more susceptible to develop diabetes mellitus, they are more susceptible to develop cardiovascular disease, they are more susceptible to develop hypertension. They are more susceptible to develop infections because their immunity is not as strong as healthy individuals, so they are very susceptible to develop physical. So every patient should get medical assessment. So this is one way of assuring quality service to our patient. We do every laboratory examinations. We do, if imaging is necessary, either we transfer or we give them the service at the hospital. So integrating mental health, medical service to mental hospital is one way of improving quality. So currently we are assuring quality by evaluating our patients and giving our patients medical service, medical evaluations. Also, we are trying to establish a surgical unit, especially for emergency patients. Still, mental ill patients have risk to surgical problems. Some of our patients might develop obstructions. Previously, what we were doing was referring to other general medical hospitals. But because of high stigma and discriminations, most of our patients not treated well at general hospitals. So to encounter this problem, what we are doing, especially this year, to establish the surgical work. So one innovative approach for the mental health service provision is integrating every medical discipline in the hospital. Our patients can have two scopes, even they are more susceptible to two scopes. So we have to integrate medical disciplines in mental health hospitals. The other innovative approach should be to general hospital. What my advice is every general hospital should have a mental health service unit. Or every department should be able to screen for mental health. Otherwise, they couldn't give quality service even to medical patients. A cardiac patient, almost all can have mental illness because of the direct effect of the cardiac problem, because of the physiological effect of the cardiac problem, patient can develop mental illness. While there is a mental problems in the patient, it will be very hard to control the heart problem. It will be very difficult to control the hypertension. A patient who has hypertension, if you ignore any mental illness in the patient, it will be very difficult to control the blood pressure. The same is in diabetes. It will be very difficult to control the sugar while the patient has stress and depression. So another approach is to give training to non-mental health professionals so that they can evaluate or they can screen mental health patients. In HIV unit, in RT unit, as you know, most HIV patients have mental illness. They have depression, they have stress because of not having, because of the things that they have the illness, because of the direct effect of the virus on the brain, because of the direct effect of the medication, because of the direct effect of the opportunity patients, the nutritional imbalance in HIV patients. So ignoring mental health in this patient, ignoring mental illness in this patient will not assure quality service. So the other is integrating mental health in general hospital. And I hope this is also, the Minister also think this way. So I hope other medical hospitals also will have a mental health service in their service. Okay? The other is maybe the technology. Maybe this will not as strong in Ethiopia. Maybe the experience might be shared from other speakers. But the other innovation what we are trying to do in human hospitals. The other problem is most of patients who came to our hospital, who present our hospital, is they came after suffering for a lot of years. So we can't treat patients at early age. What we are planning this year is also we are preparing a project. We wrote a concept paper. Just work with some Ministry of Education and the schools so that we can get mentally ill or we can screen mentally ill children at school level. If you teach or if if we train teachers working in the school, if you give them some screening tool, they might able to detect children with mental illness. With this, we can approach children in the school, and with this, we can treat mental illness at early phase. So the other innovative approach would be treating or giving treatment at early age. The other will be reducing premature deaths. To reduce premature deaths, as I've said already, integrating or considering mental illness is a part of medical illness is one way of minimizing or reducing premature deaths. A medical patient can have psychiatric illness. If the psychiatric illness couldn't be treated, it will complicate the medical illness. This will cause premature death. Also, a psychiatric patient might have physical illness. If you ignore treating the physical illness, this will also cause premature death. So, working on this side also reduce premature death in mental ill patient as well as also in medical patient. Also, suicide is very important because of premature death. So, early treatment and aggressive treatment will reduce the premature death due to suicide. The other is very necessary medications, new medication for the patient. Concerning our hospital, we have first generation and second generation, and we are almost most of the time we avail the drug, but sometimes some important drugs might not be available, like clozapine. Otherwise, most of the time we are trying to give a quality service to our patient. The other is treating patients with machines like therapy, and we are doing this, and this is all I have time.
Okay, thank you, Dr. Lulu, for raising really critical issue from point of practical experience at Emmanuel Mental Specialist Hospital, and also the point which can be taken as fix the software while you are fixing hardware. I think we'll come back in summary later. The same issue will be addressed by Dr. Birra, especially from the perspectives of neurology from inside to out. Please, Dr. Birra.
Yeah, I want to first say thank you to the Birra Foundation for inviting me, and the Oromia Health Bureau, of course, and all the participants and guests and fellow panelists. Small correction, but I'm actually neurosurgery trained, so my perspectives are more from a surgical aspect. So I'm at the University of Minnesota in the neurosurgery program, and our intersections with mental health are really seeing the sickest of the sick, the medically refractory patients who really have reached the end of the line in terms of management. So in our clinics are some of the sickest patients, the most depressed, the ones that have failed multiple, for example, major depression disorder, patients that have obviously failed medical management, have failed electroconvulsive therapy, multiple rounds, and have reached the end of the line. It seems quite odd to ask a surgeon to come and fix a problem that's classically fixed with medication. So, when we encounter these people in the clinic, often our psychiatry colleagues are there. It's quite evident to us that this is a patient that has reached the limits of what medical management can do. So, from the neurosurgery side, our perspectives go back many decades, and I'll be giving a bit of a discussion on this later in my talk, but the original role for neurosurgery in psychiatry goes back to basic lesioning. So neurosurgeons many decades ago in the United States and abroad would perform something called lobotomies, which were essentially causing severe damage to the frontal lobes. And this, at the time, would produce a very subdued phenotype, which was confused for success. So rather than having a patient who is medically refractory, who is having active suicidal ideation, who has all the negative symptoms and positive symptoms of schizophrenia, now without a frontal lobe and without an ability to coherently discuss or interact with the world, is now being told, you're cured of schizophrenia. So most at the time considered this a success, but obviously we have modern medicine and modern perspectives now to tell us that a subdued person without a frontal lobe is not cured of schizophrenia. So, I think that's an interesting perspective that, like I said, I'll talk about more in my talk. But modern neurosurgery, modern neurosurgery's intersections with psychiatry is mostly neuromodulation. So, deep brain stimulation, vagal nerve stimulation, cortical stimulation. These are techniques that neurosurgeons have for, again, most medically refractory patients and the sickest patients in the hospital. For us, what we, for some people, particularly at the University of Minnesota, we have a very robust neuromodulation program, particularly the deep brain stimulation program. Most of deep brain stimulation is reserved for movement disorders, so essential tremor, Parkinson's disease, dystonia, but a large part of deep brain stimulation is actually reserved for a lot of mental health disorders, such as treatment refractory major depressive disorder, bipolar 1, 2, and bipolar 2, post-traumatic stress disorder, self-injurious behavior. These are all modern indications that 20 years ago, if you considered deep brain stimulation for post-traumatic stress disorder, you'd be laughed at. These are now even very recent publications on phase 1 trials are showing a tremendous amount of toleration and success. So these are mostly off-label use, and these are devices being granted humanitarian exemptions, but the success can certainly not be ignored. Most of these treatments are actually done in an interdisciplinary way. So the neurosurgery department performs these procedures in coordination with our psychiatrists. So oftentimes in the operating room, our psychiatrists are there with us just to show how intimate our relationship is with the psychiatrist and treating a patient that often the psychiatrist has known for decades and has really been struggling to manage their disease process. So much to what my colleague was saying in terms of interdisciplinary involvement with other specialties, it really, mental health is really a disease that extends to many departments, including neurosurgery and neurology. Oftentimes, in the discussion of who gets deep brain stimulation, who gets vagal nerve stimulation, this is really done as a group in case conferences. Having attended those myself, it's a very interesting discussion board. You will have psychiatrists very strongly advocating for their patients that obviously they've known for many years. And then a neurosurgeon will oftentimes be the one to decide, are there any actionable targets here? The research potential is obviously very huge in this area. The University of Minnesota in particular has a very robust imaging program, and they are working on techniques to better identify targets for deep brain stimulation. So, I don't want to get too much into the details of techniques like cortical stimulation, deep brain stimulation, but the basic motivation is implanting an electrode deep into the brain that can stimulate with high frequency an area that modulates greater pathways that obviously connect to frontal lobe and other areas that modulate reward, excitability, emotional ability, and some of these pathways that have direct implications on many of the mental health disorders that we'll talk about today. So obviously this is a program that is very costly currently, but it's really on the forefront of what's possible. And I think as an Ethiopian, I can't help but think it's only a matter of time until some of these technologies come here and we're able to discuss about some of these very new and growing indications.
Thank you, Dr. Birra, for the points you have raised on the innovation, the role of innovation in mental health treatment, especially regarding the neurosurgery and the new approach to the treatment of mental health care. So now, to the end, when I summarize our panel discussion, first, the issue of training of mental health professionals in Ethiopia, pre-service and post-service and training service. It was really started gradually through diploma graduates, which is about 20 years back. And nowadays, we have much, probably to our context, when you compare with the previous, we can say much amount of psychiatrists in the psychiatric center. We have about 560 master's graduates, as well as about 2,377 BSc graduates. So even though when you compare with that of WHO standard to the professionals population ratio, the standard is really very far away back. Still, to our context, if we able to use or able to get these professionals on the practice, I hope they can do their best. Regarding the research addressed by Professor Talaka, similarly related to that of training approach, we have been following previously, like cross-sectional and other kinds of research, even not much attention given. But nowadays we have kinds of longitudinal studies, even though we have some limitations of data nationally as well as on some areas, especially the child substance and others, as raised by Professor Talaka. We also need operational research. For example, as starting from yesterday on this panel discussion, there will an issue being raised, which is paradoxical approach of integration. Integration is really good approach to decrease stigma and also to make the mental health service accessible at the community level. But when it pushes the country professionals, make it unemployable, so that's another burden to the nation. So even though the integration approach need to be further addressed by the research, whether it's effective or not, the other issue which pushes the professionals also needs to be considered, and the privilege of mental health in Ethiopia nowadays. It's really concerning issue, public concern, as everyone will not is noticing, big notice in our area of work or living because of different factors as raised on this discussion from our analyst professor. So lots of biopsychosocial risks are being nowadays much, especially the association of our context, natural and man-made crisis, are contributing mainly for the emerging of or even raising the scale of mental health condition in our context, substance, social media issue, as well as parental, as well as the presence of different stressful conditions in our context. So to the policy and again translating, aligning our strategies as addressed by Sister Agitu, there is a priority area of the collaboration partnership as well as coordinations. Even nowadays what is being done well is previously professional associations and government agents most of the time like asking them again response, but now time for collaborations is the COVID. This more on this area, and the professional associations are collaborating with the governments, starting from ministries and the regional health bureaus and other agencies, just working together and contributing their part using their expertise, and also that is the major that can be raised, though things still need more improvements. Again, the research, which especially national data regarding mental health, data capturing, which was in yesterday also raised. For your surprise, only depression, I think, if not mistaken, depression and psychotic disorders only reach as data aggregate for the policymakers. But as mentioned earlier, psychotic disorder or mental disorders are more than 300. So these only two illnesses that influence policy, and that makes not to give attention and need to be further worked on. So the role of professional association, as raised by Mr. Tegani, yeah, we do have much professional associations, but there is limited capacity as well as especially engaging the gap using the research and the different further approaches to fill the gap of practice. For example, in our context, even there are policies in design law which give larger capital, larger responsibility for professional association to, for example, to the level of licensing the professionals, as well as to try their best in keeping the standards of service at the national level. So that is good thoughts if it's supported by the capacity building of the health professionals. To the innovation, when I summarize, Dr. Lulu will address it, and even practically what's been tried at Amman, especially hospital, especially creating the medical care to the mental health care. So mental and medical health is really integrated and connected. We can't handle them differently. So bringing them together, caring for both, as I earlier said, ICT professionals when fix their PC or like computer, software and hardware. So if you only fix the hardware and neglect the software one, doesn't work. And again, if you only fix the software and the hardware are still fragile, doesn't work. So those need to be fixed together. That's what can be taken as a good approach, as innovation to all levels of our practice, starting from higher tertiary hospitals to the level of primary health care, and also the innovation approach which has neurosurgery, neurology as well as mental health are interlinked. So the activities which now as innovation being done in Western and other countries, especially like brain stimulation and implementing of the stimulators and neurosurgery, all these for mental health treatment, and we will address if used very wisely. So this is all what we have for this session. I do really appreciate the panelists for sharing their insights, and also once again I would like to appreciate Oromia Regional Health Bureau for coming in front by just planning this large event. Personally, I can't have words to express my gratitude for them, and also ALIBIRA Foundation, our family, really appreciate the area they collect, and really something we need to work if we want to have full well-being of our society, and all of the researchers and all the guests and all the participants of these events. I really appreciate what we have shared on this event starting from yesterday. Thank you very much.
Important addressing of this topic. So one of the two panel sessions we have on this conference. Yesterday we have entertained the first panel session, which is really trying to diagnose our healthcare system. Where is our healthcare in terms of making sure of accessibility of the mental health care services. And today we have seen this panel, which is very important, really to the complementary to our established session, that is research, training, and the policy perspective. So by this, I hope all of us, all the policymakers, the practitioners, the researchers are here are giving important take-home messages. So now we have some announcements. So the time for now is for tea break. So the tea break will be only for 15 minutes. So by that we are also having some visits like we do earlier today. That is exhibit visit, and the poster presentation is also there. So you are invited to that. And next to this, the parallel session will follow our yesterday's arrangement. So you are invited to that. After that, based on our performance in these sessions, so we are going to arrange our following sessions. So now you are invited to the tea break.
Dr. Taha represents a new generation of neurosurgeons dedicated to pushing boundaries of pediatric brain health. His topic of presentation will be mental health from the inside out perspective, from the neurosurgery side. So Dr. Taha will continue.
This is really a perspective from neurosurgery, as you can tell. The views here are more from a surgical perspective, but I really wanted to take a step back and look at how does neurosurgery intersect with psychiatry? What does a neurosurgeon have to say about mental health, and why am I here kind of discussions? I think I wanted to frame this talk from looking at the origins. So what has neurosurgery done for mental health, and what exists in the literature, what attempts have been made, what are the technical aspects of what neurosurgery does that can benefit mental health? Because it's certainly not the first thing you think of when you think of mental health. And then second, I'm going to talk about a particular aspect of what neurosurgeons can offer in the mental health world, which is neuromodulation. So particularly I'll be discussing the rise of deep brain stimulation, the now even broader indications that are coming with deep brain stimulation. And then, because obviously I'm going from neurosurgery, I'll briefly discuss some of the technical nuances, what goes into deep brain stimulation. And then, again, I will talk about some of the emerging indications that some of myself and other colleagues have been working on. And I think it'll be a bit of a glimpse into the future as well. So really, the field, the intersection of neurosurgery and psychiatry really created this growing field called psychosurgery. So beginning in the late 19th century, 1889, the complications of neurosyphilis, which would create higher intracranial pressures chronically. So patients would come in presenting as a mental health disorder, quite subdued, no obvious other manifestations, but would be successful when trepidation was performed, essentially creating a hole in the head. The patient was able to recover and for however minute of a time, given its untreated neurosyphilis. But the sequelae of this, treating the increased intracranial pressure, you were able to have a person who clearly showed some improvement from surgery. So the idea of surgery helping what seems like a mental health disorder, this idea was planted, maybe 150 years ago, 40 or 50 years ago. And then, not too not too much longer later, this idea was extended into the idea of giving patients that are at the time medically refractory schizophrenics, what can neurosurgery do in terms of helping to manage disease control? Some of the early studies and sheet models actually showed that lesioning the frontal lobe would do something in terms of modifying the personality. At the time, it was not well understood. So what they had done was essentially just open the head and cut out part of the frontal lobe. And the outcomes were quite poor. And again, there was some confusion as to what is a success for somebody who was so debilitated by schizophrenia, having your inability to live a regular life. So, however, there was consensus at the time that these were poor results. So there was a Portuguese neurologist, in fact, who, after reading some of the early literature about what lesions in the frontal lobe of monkeys had modified their personalities, he had the idea of intentionally lesioning people with mental health disorders, spanning everything from schizophrenia, major depression, catatonia. So his approach was essentially creating a burr hole, so an opening in the head on each side, and with a needle actually going deep into the frontal lobe and injecting alcohol. So he was essentially intentionally lesioning both sides of the frontal lobe. And again, he was particularly interesting because he was very forward in proposing that this form of neurosurgery would change mental health. And he was actually a strong proponent of lesioning this way with the injection of alcohol. And again, he was a neurologist. In fact, he was so successful in advertising this technique that he actually won the Nobel Prize for it. He's one of two psychiatrists in the history of the Nobel's history to ever receive a Nobel Prize in medicine. So this was 1949. So taking his technique, an American neurosurgeon and American psychiatrist, Watson Freeman, essentially standardized his technique through an incision above the eyelid. So coming above the eyelid, this was actually an attempt to make this as minimally invasive as possible to be done by psychiatrists in the clinic. So his technique involved, as I said, an incision above the eyelid, and then an instrument called an orbitoclast was essentially with a hammer and a mallet, was malleted into the frontal lobe, and then passed another instrument, and essentially just swept all of the white matter tracts in the frontal lobe, left and right. This was done via a unilateral approach. So again, this was a technique that was popularized in the United States, and in fact, continued in popularity through the 40s, 50s, and 60s as a continuation of Dr. Gomes in Portugal's technique. So essentially, an American standardized version that at the time was actually receiving a considerable amount of popularity and was leaking into the mainstream as a way to treat medically refractory patients of any kind. Or, in fact, this idea was extended into any patients deemed abnormal in any sort of mental health sense. As broad as that is, that was actually some of the implications. So this was, in fact, extended. Extended into modern day so pervasively such that, so this is an example of a patient who received a lobotomy. So this was Rosemary Kennedy. So this was siblings with Senator Ted Kennedy. So this was a child who, by all accounts, was a very regular kid. At the age of, growing up, she was never described as anything other than normal. But I think by the Kennedy standards, she was described as not up to speed as the rest of her colleagues, given the popularity at the time of these lobotomy approaches. She actually underwent a procedure done by Dr. Freeman, this psychiatrist who popularized this technique. He personally did a procedure at the age of 23. And after the procedure, she essentially became bed bound, totally dependent. And she lived, after the age of 23, lived the rest of her life in a nursing home and passed away only at this point 20 years ago. So this was a story that I think was intentionally hidden from the community for many years, and only recently has received a lot of interest. So a lot of these patients who underwent lobotomy as children underwent them in very loose circumstances and very loose indications. Their definitions of medically refractory at the time were much looser than what we would consider now. So surgery was considered like essentially a bailout for anybody who wasn't acting the way that they should. So putting that aside, moving forward, we're at the point now where we're doing things much more complicated than this. We realize that lobotomy and these techniques actually don't work in people, and those are not durable techniques. Many of the neurosurgeons, psychiatrists, neurologists who performed these lobotomies actually intentionally did not report their complications. So many of them had intracranial hemorrhages. In fact, Dr. Moniz, one of his trainees, secretly recorded some of these complications that they numbered into the hundreds, if not thousands, and Dr. Freeman and Dr. Watts similarly so. But we're at the point of deep brain stimulation. So deep brain stimulation is essentially this high frequency stimulation deep into the brain. So what happens is we pass an electrode deep into the brain. The target can be very variable depending on your disease of interest, but the tip of the electrode ends up in your target. And using these high frequency simulations, you actually modify a greater circuit in the brain that includes that target. So it's not directly affecting the pathway, but sort of indirectly modulating it. The targets, so it's considered deep brain because most of the targets are quite deep. They're mostly subcortical. Thalamic nuclei, globus pallidus, these are very pervasive targets in mental health disorders, but also in movement disorders as well. So deep brain stimulation really started out of movement disorders, dystonia, essential tremor, Parkinson's, but really it's been expanding nowadays into psychiatry. There's almost a reemergence of psychosurgery in a more controlled fashion, obviously. So, when we do these at the University of Minnesota, it's really multidisciplinary. So our colleagues from neurology help us with microelectrode recordings. So as the electrodes pass into the brain, the neurologists are actually able to listen and map the action potentials of the neurons at each nuclei and help us determine when we are exactly in the nucleus that we are of interest in. So that uses microelectrode recording. Other centers use stereotactic guidance, so using precise imaging to place it exactly where you want. The last thing you want when you're trying to do deep brain stimulation is put the electrode where you do not want it to be, or in a suboptimal location. And we do this with a single semicircular incision and a single burr hole, and the electrode is passed through. From beginning to end, microelectrode recording, the procedure itself takes about 3 to 4 hours. And the battery is actually placed in the left chest wall here. And again, this is all under the skin. It's stimulating at all times. Many of the current technologies have not just a pulse generator, but also the ability to record some of the action potentials from here. So it's actually recording, stimulating. And depending on what kind of research you're into, you can imagine the ability to record from these deep nuclei will be very powerful in asking innovative questions for biomarkers and things like that. So, I want to just touch on some of the more current data as to what deep stimulation can do, including in children. So, in a study from University of Toronto Hospital for Sick Kids, my colleague Dr. Georgie Graham, actually they have a very recent publication showing in self-injury study deep brain stimulation actually has a tremendous amount of potential. And their work is actually really on the forefront of what's being done for these really severe cases in children. And their target is actually the nucleus accumbens. In adults, there have been bigger studies that show that there is some efficacy in modulating some very important pathways. In their case, they do bilateral stimulation, and their successes have been presented on numerous conferences. So another growing areas of post-traumatic stress disorder. So PTSD is considered essentially an emotional imbalance, particularly modulated in this inability, poorly modulated, I should say, this ability to manage fear and this concept of fear extinction. An unchecked, dysregulated system leads to impaired conditioning, unregulated management of fear. So with this impaired extinction leads to this hyperactive amygdala that has been documented in numerous functional studies. So this is almost a prime target for deep brain stimulation. Some of my adult colleagues, I think at the University of Washington, have shown that their results are quite durable. There's an earlier study showing efficacy, and now some of these results in these very severely affected patients with PTSD. And then substance use disorder is also a rising indication as well for many of these medically refractory cases, like I've said. Nucleus accumbens is a very popular target, but ventral striatum and interior of the internal capsule as well. But these are now reaching a randomized controlled trial level and are showing a tremendous amount of efficacy for many different substance use disorders, including alcoholism, cocaine, heroin, and all these other areas. This is an example of specifically for treatment-resistant alcohol use disorder. Another very interesting disease process is obsessive compulsive disorder. This disease often co-occurs with many other mental illnesses, but in particular, the University of Minnesota has a very interesting case series of these patients who have stimulation of ventral striatum. I can recall one case of a patient we had who was a young man who had severe progressive OCD, but also had co-occurrence of mania as well. So we were quite worried about if we were to offer different stimulation of triggering a manic episode from our stimulation itself. So we actually worked with him quite closely, and he actually modified the stimulation given his OCD would at times fluctuate. He was actually given a remote control to actually be able to modify some of the stimulation. So we made sure that control obviously had a very low ceiling and a very high floor, so there was not much room for abuse in this case, given that he is somebody liable to manic episodes. But to me, that was one of the first cases where it was very clear that things are changing. Things are not where it was 10 years ago. So in these cases, these patients have a tremendous amount of benefit. In this patient's case, he was able to go back to school. His OCD was so refractory and so severe that he actually lost his apartment, lost his job, wasn't able to go to school, and moved back in with his parents. After the stimulation, within 2 years, he was back in school and had perfected his stimulation settings, so we knew exactly where he needed to be. So, but OCD in this manner has really changed the forefront of what's being offered, particularly in these treatment refractory cases. I think being able to say, at least we have these targets that have significant amount of efficacy is an important thing to offer when you're talking to patients in the clinic. So, yeah, okay, that's what I have.
Thank you, Dr. Lula, for your nice presentation. Now we will proceed to the second presentation. Our second presenter will be Dr. Alison Johnson. Alison Johnson has been a nurse for more than 50 years in the psychiatric nurse practitioner. For a dozen years, she had an early career as a hospital nurse and in administration. She earned a master's degree in business administration and worked as a healthcare consultant to the United States, Europe, and Asia before earning a doctorate in psychiatric nursing. She is a registered poetry therapist and incorporated poetry and cognitive behavioral therapy into her most recent work with homeless people residing in Minnesota. She serves as a surveyor for the National Committee for Quality Assurance, surveying managed behavioral health organizations for compliance with national standards. Her presentation title is Mental Health Stigma Across Cultures and Poetry Therapy. I welcome her.
I appreciate being here. Birra, you're a hard act to follow. So hopeful about refractory psychiatric conditions and the thought that surgery might be the answer. How unexpected. So I'll be talking to you about stigma today. Let's see if I can do this. So just a quote for you, and this came from a study that was done in Ethiopia last year. No nation or culture places the same value on people with mental health conditions as those without. So no nation, no culture values people with mental health conditions as much as they value people that do not have those conditions, which you can see right away leads to people not wanting to admit that they've got a mental health condition. Two objectives today. One is to understand the overall impact of the stigma of mental illness, and the second is we'll be discussing some of the possible, I've got 5 possible solutions to reduce stigma. The most typical form of stigma is right here. So people with mental illness are considered to be homicidal maniacs, even though we know that people with mental illness are far more likely to be victims of violence than to perpetrate violence. The second one is they're considered to be rebellious, free spirits who don't follow rules. Or thirdly, childlike people that must be cared for. So internationally, across the world, these are the most common beliefs about people with mental illness. So if you hold that belief that people with mental illness are homicidal maniacs, well then people fear them, and people are reluctant to engage with them, and people feel especially that they should be punished or they should be locked up, they should not be among normal society. If they are considered to be rebellious, free spirits that follow their own rules and don't pay attention to societal norms, well then they're considered irresponsible people that can't hold a job, that can't take care of business. And the third impact is for people that consider those with mental illness childlike, then they're not offered the opportunity to have jobs, to have independent lives, if they're considered to be helpless. And many times then the parallel with that is they're also considered to be hopeless, that there's no hope for them, they always must be cared for. Well, these are the 3 most common forms of stigma around the world. There are many others as well. And you probably recognize some of this. So some people consider the mentally ill to be cursed. That means that they must be avoided at all costs because of the curse. Some people are considered to be lazy. They simply aren't trying hard enough. This is very true about people that have depression. Just snap out of it. You're just lazy. A third one is that people have caused their own illness. And this is particularly true of substance use disorder. You have caused your own illness, therefore the consequences that accrue to you are deserved because you did this to yourself. Another possibility is that people are possessed by demons, and we'll see that treatment is of a religious variety. We hear about people going to holy areas to pray for themselves, exorcists that happen with people. So all kinds of treatments that happen aimed at the fact that this person is possessed by devils, not subject to a mental illness. Got to catch up with my slides here. One of the sad things that happens is not only is the person with mental illness stigmatized, but so are their friends and family. And there may be a sense that the families, that mental illness is hereditary, and therefore the family is to be avoided because one member suffers from a mental illness. Friends can suffer as well. Why would you want to associate with someone who has a mental illness? And there's a sense that maybe mental illness is contagious, Or maybe you see something in that person that nobody else can see because people with mental illness are so devalued. And then it spreads. So people that treat people with mental illness are also stigmatized. Why would you want to work with people who are mentally ill? Maybe there's something wrong with you if you want to treat people with mental illness. And I can give you an example from my own neighborhood. I live on a street that has 3 nurses. 2 of them are, one is a medical nurse, the other is a surgical nurse, and I'm a psychiatric nurse. Who do my neighbors turn to when they need help? Let me tell you, it's not me. Nobody wants to be seen coming to my door asking for help. The other thing that happens, and I think this is probably the saddest part, is that people self-stigmatize. So they think less of themselves because they're suffering from depression or schizophrenia or bipolar disorder. So they consider themselves not worthy. They consider themselves hopeless and helpless, unable to manage their own lives. This is a real downward spiral for people with mental illness and extremely dangerous as far as being able to eventually recover from mental illness if you believe that that's impossible for you. So, and then I think one of the worst things is that, and I have seen this, is that mental health providers stigmatize their own patients. So they consider their patients to be incurable, helpless, hopeless people. So they stigmatize their own patients. And the result, of course, is discrimination, because people with a mental illness are isolated and excluded. So they're not welcome in polite company. They're not encouraged to socialize with others. Their jobs are harder to get. In fact, on job questionnaires, often it will ask, have you ever suffered from a mental illness? And people are afraid to answer that question because of the consequences that can accrue to them with that. Family and neighbors do not come to visit anymore. They don't want to be associated with someone with a mental illness. Law enforcement may consider a psychotic break as criminal rather than as a symptom of mental illness. And then what happens to the person with self-stigmatization is that they're ashamed, and so they don't go out into company themselves. And as a result of this, what happens is people's vision of mental illness is only those people that they might see in public who are having a severe episode. Many people believe that they have never seen a well mentally ill person, that they have never seen one because people don't talk about it when they're well. The effect on mental health care workers is also fairly extreme. So there's a very heavy workload as many people choose not to work with mentally ill people. So the workload is heavy. In fact, I had a hard time retiring. I finally retired when I was 72 because the need is so great among for mental health workers. There's also frustration and discouragement. In the United States, the lowest paid specialty is psychiatry. There's also fewer opportunities for education and training. When I was looking for a fellowship program as I completed my doctorate, it was very hard to find one in psychiatry, not hard to find one in surgery. So what do we do? Well, we know that there are some things that actually work to reduce stigma. Number 1 is the treatment of people with mental illness. So we know that there are limited resources. However, if we can get to and treat people with mental illness, depression lifts, psychosis comes under control, people start to be able to live a more usual life. So number 1 is that treatment so that mental illness is not considered incurable. Mental illness can be stabilized. So this is the very first strategy to reduce stigma, is to treat people with mental illness. Give them hope, give their communities hope. A second approach to reduce stigma is social contact. So many times people that suffer with a mental illness are reluctant to go out, reluctant to talk to people. They don't want anyone to see them as mentally ill. And so they isolate themselves and enter this spiral of feeling worse and worse about themselves, of not seeking any kind of help or treatment. Their family starts to treat them differently. Their community treats them differently. And I think about the story that Lily told us about ALIBIRA and the mentally ill man who approached their car. He socialized with that man. He reached out to that man. And that is what we need to do, is to socialize people with mental illness. So this is a second strategy to reduce stigma. A third one is to integrate mental health with primary care. This might seem a little counterintuitive, like, what does primary care have to do with mental health? But when people with mental illness are free to discuss with a primary care provider symptoms of depression or anxiety or sleeplessness or hallucinations, they are able to enter treatment sooner. And it's very common for primary care to be able to treat those beginning symptoms and then refer on to psychiatric specialists if things prove refractory. But integrating mental health with primary care is a very important strategy for getting people early into some sort of treatment. And I'm sure I'm not alone in this experience, that when I see my own primary care doctor, she usually wants to say, so I have this case, and I wonder if you could give me some advice. The fourth thing is to educate the public about mental illness. So there are a whole variety of programs around the world that are aimed at reducing the stigma that's associated with mental illness. And I want to point out a few for you. NAMI is an organization in the US that's very active, and you can see the website there. Germany and Italy have a very strong program. One of the strongest is actually in Australia, SANE Australia. New Zealand, the World Psychiatric Association has programs, and they're aimed at educating the public about mental illness, helping people see how treatable it is and helping see how normal it is. You know, I was looking at the poster presentations, and the prediction is that about 80% of the Ethiopian population is at high risk for mental health issues. How can we ignore this? How can we ignore this? We need to educate the public about that. And then the last thing that I want to point out is the protest. So when you hear someone speaking negatively about someone that has a mental illness, you follow ALIBIRA's example, and you treat that person kindly, you treat that person well. You can lead with the things that you say to someone about, that's not quite right, let me give you some additional information. Or you can lead with your example, the way ALIBIRA did, by treating people with mental illness as worthy individuals. I want to give you some resources too. So these are some references, but even more importantly, these are some resources that help educate yourself and help educate your communities around that. If you would like a copy of these, Susan, would you stand up for a moment? You can give your email to Susan, and she will get this list of resources to you and references to you. They're fascinating websites to look at, to see the information that they have and how well they represent the community of mental health workers. So thank you to the foundation, to the ALIBIRA Foundation, and to the Remote Health Bureau for inviting me to speak on this important topic.
Thank you, Dr. Alison, for this nice presentation. Now we will proceed to the third presentation. Our third presenter will be Dr. Adil Katabai. Dr. Adil Katabai is a renowned international pain medicine specialist based in Maryland, Ohio, with other 2 decades of clinical experience. He earned his medical degree from the University of Wisconsin in Madison, followed by an anesthesiology residency at the University of Minnesota in Minneapolis. He completed his fellowship in pain management at Bethesda Diaconus Medical Center. As the founder of PKC Pain Specialist and Regenerative Medicine Clinic, Dr. Katabai has built a practice dedicated to improving the quality of life for individuals suffering from chronic pain. Dr. Katabai has received numerous accolades, including Most Compassionate Doctor top 10 doctor in Ohio, Patient's Choice Award, America's Most Honored Professionals, top 1%. Dr. Kataba is fluent in English, French, Arabic, and also Afan Oromo. His keynote presentation is chronic pain, mental health, and suicide. Now I open the floor to Dr. Kataba.
Assalamu alaikum. Assalamu alaikum. Welcome to inshallah. So first I want to thank Dr. Birra for inviting me to this, followed by Adad. And I want to thank all the groups that are coming from the US for joining me as well. I want to thank the ALIBIRA Foundation. Thank you very much for allowing me to come. And also the Oromia Health Bureau. I look forward to, inshallah, doing more with Ethiopia in the future. But having said that, my topic today is chronic pain, mental health, and suicide. I am an anesthesiologist, trained in the US and did a fellowship in pain management. So I have a pain practice. It's an interventional pain practice. It's looking at the holistic patient and looking at the reasons for their pain and also what other comorbidity they have. Having said that, so I'm in private practice. I want to go over a few things. Number one is overview of pain, risk factors, assessment of pain, causes of pain, comorbidities, treatment options, and then closing, inshallah. As you may know, there's two different types of pain. One is chronic pain and the other one is acute pain. Acute pain is anything, most of us in this room have had some kind of pain in our life already. And if the pain stays with us less than 3 months, then it's considered acute pain. When it's beyond 3 months, that's when the definition of chronic pain kicks in. There are two types of fibers that are being involved, the A delta and C fibers in terms of the pain fibers. There are some risk factors that comes that if you have them, you have a tendency of having pain. One is genetic. You know, if my mother had a history of migraine, I may end up having migraine. Or a family member had rheumatoid arthritis, I may have it as well. Aging, obviously, as we get older, we have weaker bones, and therefore we tend to fall and tend to fracture bones, which causes pain. Obviously, previous injury. I've had a lot of my patients would come to me telling me that they've had a car accident 20 years ago, and then suddenly they're having the pain now. So it's a progressive arthritis that accumulates over time. Manual jobs, if you're lifting heavy things, then that can cause you to have pain. PTSD, you know, Dr. Birra was talking about PTSD earlier. The fact that there's stress in people's lives, your stress hormones get increased in your body. The stress hormones are your cortisol and adrenaline, norepinephrine. And we'll talk about this shortly, but chronic pain and mental health are so interrelated because they use the same biological pathways, using neurotransmitters called the norepinephrine and serotonin. So anybody who's under a lot of stress, they have an increase in cortisol, increase in norepinephrine, which causes them to have more pain. Obesity is another risk factor. When a patient comes to me, and these are the kind of questions that I ask them, what kind of pain do you have? Whether it's dull, sharp, shooting, burning, and I want to know the locations of their pain, the durations, when did it start? When did And then the frequency, is it always on? Is it always, every hour you have this discomfort, or is it constantly there? Intensity and severity, obviously this is subjective. I ask a patient, hey, what's your pain like from 1 to 10? They keep telling me a 10. My 10 is different than your 10. And so just keep that in mind in terms of the subjectiveness of this. I also like to ask them about their daily activities. If there's any constraints, what seems to be bothering them on a regular basis. Causes. Sometimes I ask my patients, what do you think has caused their pain? And I'm surprised to see a lot of them would actually tell me the exact injury that they have started it. Then I do physical examination, including reflex and balance testing. We do blood, urine test, EMG, X-rays, MRI, sometimes spinal fluid testing. But these are the kind of tests that we think about. Obviously, when it comes down to causes of pain, you've got so many causes. Again, I just want to reiterate that when it comes down to chronic pain and mental illness, you've got that neurotransmitters that are kind of interrelated. So you've got patients who have PTSD that suddenly have pain. And we've got patients that have depression or anxiety that suddenly have pain, and vice versa. But these are all the medical conditions. You've got muscular skeletal disorders, nerve damage. I know I've got 20 minutes, so I'm trying to go through this really fast. Infections, shingles, Lyme disease, autoimmune disease. In terms of the autoimmune disease, these are just, your body's rejecting some tissues, and usually it's in the joints, and that causes pain. Cancer, you can have bone mets, you can have a lesion that is pressing on the nerves. Stress, anxiety, depression, like I mentioned. Injuries, like I mentioned earlier, lifestyle factors we kind of went over in terms of obesity and if you have lack of physical activity. Medication, surprisingly, could cause pain. And then in some cases you have, we don't know what the causes of pain is. The cause of pain. I kind of talked a little bit about this in terms of comorbidity. Depression and anxiety, it's 4 times as likely compared to general population with patients with chronic pain. Suicide, twice as likely compared to general population. This is because the patients who are in chronic pain tend to be depressed, anxious. They may be unemployed because they miss work because of their pain. They also may be involved in substance abuse, drinking alcohol or doing drugs because they're sick and tired of their life, because they're always in pain. So there's a lot of suicide that comes through the sense of feeling helpless and hopeless. They're spending less time with family members because they're in pain. As grandparents, they can pick up their grandkids or pick up their own children or whatnot. So there's a lot of this feeling of worthlessness, which leads to the suicide. So I kind of already talked about the overlapping biological pathways in terms of the neurotransmitters. Treatment option, this is also a big one. One of them is, when I have a patient coming into my practice, I have a holistic way of looking at the patient. I make sure that they're seen by my psychologist that is not in my practice, but I send them to my psychologist, making sure that if they have any kind of mental illness, they're also being treated for it. Because I can't just treat them with pain medication or injections or physical therapy. It has to be a holistic way of taking care of them. So I have my psychologist talking to the patients, coming up with a treatment plan. I also have a compliance provider that checks and makes sure that these patients don't have the risk of abusing their medications. So it's like my way of protecting my practice as well. The psychologist that I sent into does a lot of psychotherapy, cognitive behavioral therapy, group therapy. There's biofeedback, journaling, coping skills, meditations, and so on and so forth. We send a lot of our patients for also physical therapy and occupational therapy because we need them to be able to be active and able to go back to work, whether that's work or teaching or whatever their profession is. So I do a lot of interventional procedures. This is not the time for me to go over the procedures that I do, but there's a lot of I do procedures. Literally, if a patient comes in with a headache, I know where to put my needle to give them relief to their headache. From a headache all the way to a toe pain, I can treat with different types of injections to relieve their pain. Unfortunately, I tell patients that when it comes down to chronic pain management, it is managing the pain, it's not curing the pain. Most of us, once we have pain, we're kind of stuck with this pain, unless it's within that 3 months, and then it's no longer an issue. I prescribe medication. Sometimes antidepressant like SSRI, because of the serotonin neurotransmitters that I talked to you guys about, not only helps with their anxiety and depression, but it also helps with their pain. I prescribe anti-inflammatory, muscle relaxants, anti-seizure medicine for their nerve pain or neuropathic pain, and then I prescribe opioids, narcotics. So, in a nutshell, when it comes down to chronic pain, most of us have had some kind of pain, and we have some family members that have had issues with chronic pain. So just remember that with chronic pain comes anxiety, depression, suicide, and substance abuse. So we need to look at this individual, this person holistically, and care for them and take care of them. I hope to return to Ethiopia, inshallah, in the future to help with this, at least chronic pain management part. But it's not just a single issue, it's just a complex problem that people have. Again, thank you very much for listening to my presentation.
Thank you, Dr. Gatabai, for your interesting presentation. We will proceed to the fourth presentation. For today, our last but not least presenter will be Dr. Abdirahman Rone. Dr. Abdirahman Rone is a hospitalist nurse practitioner at North Memorial Hospital. He also served as a medical director for the community vaccine clinic program, where he leads community health initiatives, including chronic disease screening with COVID-19 education and the global health projects. Dr. Rone has a strong interest in global health and is actively engaged in strengthening healthcare systems in East Africa through partnerships, trainings, and resource mobilizations. The topic for this presentation is mental health in hospital medicine. I open the floor to Dr. Abdirahman.
Mental Health Day. Just want to say a few things about it. Today is a Mental Health Day. Mental health is a cornerstone of our overall well-being. Mental health is not just the absence of illness, it is the presence of balance, purpose, and compassion in our lives. Let us remember that seeking help is not a sign of strength. Let us remember that seeking help is a sign of strength, not weakness. By talking openly, supporting one another, and breaking the stigma, we build communities where everyone feels seen, heard, and valued. As we mark this Mental Health Day, may we renew our commitment to caring for ourselves and for each other with kindness and understanding. Together, we can make mental health a universal priority. Thank you. Okay, let's talk about the mental health and hospital medicine. Today we are going to cover 4 areas. First of all, recognizing mental health in hospital setting and identifying common psychiatric conditions that we see as a provider in the hospital, and apply some evidence-based approach to screen for those mental health issues, and promoting equitable and cultural response in mental health care. I think we have heard about this yesterday. According to WHO, 1 in 8 people globally live with mental health. That is huge number. So always mental health needs to have get a priority everywhere. And if you look at the mental health disorder, that is contributes significantly to years lived with disability. Earlier, one of the presenter was talking about like people with mental health disorder, they die 10 to 15 years earlier than those without mental health. So that is a big number. In hospital medicine, psychiatric comorbidities increases length of stay, readmission, and mortality. We see this all the time. If someone like come with, let's say, hyponatremia, but they already diagnosed with depression, and some of the medication that they take for depression will cause hyponatremia and makes the management really severe, and that prolongs their hospital stay. And for all these, hospitals are the key touch point to detect, stabilize, and link ongoing care. It's not just only treating patients in the hospital, but make sure that this person or individuals with mental health can get the service that they need or the help that they need after discharging from the hospital. We heard a lot about depression and anxiety already in these 2 days, because those are really the common cases that we see in the hospital. And delirium as well. I don't work in an ICU. I work in just med-surg units, and I see patients, especially seniors, like geriatric populations with maybe infection or sepsis. They tend to have delirium. And we see a lot of substance withdrawals, especially alcohol-related cases in the hospital, and suicidal ideation and self-harm is another problem. There are really so many different screening tools. I'm not sure how many of these that you guys use here, but for depression, we first use PHQ-2, Patient Health Questionnaires 2. There are a few questions that we ask. The first one, I'm going to read it from here. In the past 2 weeks, little interest or pleasure in doing things, that is one question. The second one is feeling down, depressed, or hopeless. And we read this out of like 4 points, not at all severe, several days, more than half of days, nearly every day. If the point or the score is 3 or more, that means it is positive, so we'll do the entire PHQ-9 questionnaires. The same with anxiety and alcohol withdrawal syndrome. We use what is called C1, Clinical Institute Withdrawal Assessment for Alcohol. And this area, there are like 3 categories. If the numbers are between like 0 to 7, it's considered mild withdrawal. If it is 8 to 15, it's like moderate, and 15 or 16 and above is severe. And there are like 10 points that we're gonna see. The same thing as delirium, we just assess their mental status, attention, and all those. And suicidal risk, we ask about if they have intent or thoughts about committing suicide. As I mentioned earlier, depression and anxiety are really the most common and also underdiagnosed even in the United States. And the diagnosis of depression and anxiety associated with increasing lengths of stay and readmission. As we say, there are a lot of complications, and those people sleep orientation. And always when the patients get admitted, when they walk into the emergency department, we always ask to do the PHQ2. And then if that is positive, we do the PHQ9. So screening is really very important. And if there is any pain related to that, addressing the pain will help with depression and anxiety. And if the patient diagnosed with depression and anxiety, really the main treatment, we usually consider SSRIs and SNRIs. But prior to prescribing those medications, we need to know more about the patient. Always, I don't really prescribe those medications without looking at the EKG. We mentioned the control QT. Some SSRIs, they prolong the QTC, which can end up patient end up getting heart attack and arrhythmia. Because of that, we have to have just a baseline EKG reading on that patient. If I don't see any EKG in their chart, I have to get one. And hyponatremia is another issue. These medications, the SSRIs, tend to trigger the SIDH, which can elevate the secretion of ADH, antidiuretic hormones, and that will increase the kidney to absorb water, and water retention can dilute the sodium, and we end up patient having hypernatremia. So prior to ordering those medications, we have to make sure that we have those information first. And already, psychosocial supports are really very important, counseling and other means that my colleagues already mentioned. Delirium, as I said, we see this more with our population age 65 and older, and who have dementia or severe illness. And sometimes if they come with like a person 65 and older with UTI, they might have a delirium. So we use the 480 assessments for like attention, inattention, altered consciousness, and based on that, we will try to really manage the delirium. Most of the time, we get a request for medication from nurses if the patients are delirious and agitated. But the primary thing is really not the pharmaceutical is not always the answer. Reorientation really helps, like bringing family to be with the patient, and even making the room more comfortable for the patient, and mobilization will help. And sleep hygiene is another approach to help with this delirium and make sure that they're drinking enough water or hydration, and minimize the overnight disruption. If really these techniques doesn't work, we go to antipsychotic. We do maybe Seroquel or haloperidol, but still we need to do the QT-C numbers before ordering those medications. I really see alcohol withdrawal a lot. 2 weeks ago, one of my patients that I was taking care of in the hospital came in with alcohol withdrawal symptoms. That person is alcoholic, and what happened was he was on CWAP protocols. There are like 10 symptoms that the nurses will monitor. And then based on those symptoms, if the number, as I say earlier, 0 to 7, is really mild, they might not need any treatment or intervention. But if it is above 8, like 8 to 15, that is moderate alcohol withdrawal and they need treatment. And sometimes we check, the nurses check the CWAP score every 2 hours. And one of my patients that I saw 2 weeks ago, he got like Valium almost like 8 times within 8 hours, and still consistently having these symptoms. And at this point, if they got medication 8 times within that time limit, the nurses reach out to the providers, and we transfer that patient because of their refractory to the ICU, and we give up that patient in ICU with Presidex. So, our patient who comes with the alcohol withdrawal, there is a risk of a seizure and delirium treatments if untreated. Sometimes we do benzodiazepine based on the CWA. And when I see the patient, regardless of their CWA score, I order thiamine, folate, multivitamin, because these patients tend to become encephalopathy. So thiamine will prevent the or leaky encephalopathy. So that is what we order as the treatment for them. And then consider IC for refractory or severe withdrawal, like the one I mentioned a few seconds ago with the patient who got Valium 8 times and then still having symptoms. So please transfer that patient to ICU for treatment with Presidex. I think we've already talked about this, the CWA monitoring every 2 hours until that patient is stable, and then we check vitals every 4 hours. Symptom trigger benzodiazepine, diazepam 10 milligram PO every 1 to 2 hours. So this person received 8 times. And if they have like hepatic impairment, we do use lorazepam. Thiamine is what we order, as I mentioned earlier. It reduces the risk of developing Wernicke syndrome, Korsakoff syndrome, and Beriberi. So we always prescribe those medications and make sure that those patients are really hydrated. And if we have the protocol for like magnesium and potassium replacement. For other general population, we want potassium to be 3.5 and above and magnesium 1.8 and above. But for patient who is alcohol withdrawal, we make sure that their magnesium is 2.0 and above and potassium 4.0 and above. So that is some consideration that we need to have. Phenobarb, usually I really never ordered, but can be ordered if needed. The next one is suicidal risk. So we ask the risk if they have any intent or thoughts about killing themselves. If that is positive, we take safety precaution, remove all lethal means, initiate observation, CETR when needed. If the patients are really telling us they're suicidal, we have to make sure that they have CETR one-on-one. So one person sit with the patient 24/7 to watch for that patient. And then develop safety plan and ensure mental health consult. We have psychiatrists in the hospital, so if there is a need, we ask psychiatrists to see that patient. And we make sure that the social workers facilitate safe discharge for those patients. This really, we have been talking about this all during these 2 days. Equitable universal health care is very important. As we mentioned at the beginning, 1 in 8 people suffer from mental illness. So in Ethiopia, I think integration and community-based care is the priority here. Expanding treatment gap, population mental health, and right-based care. Right-based care reduces stigma and coercion, engage families. So if we see patients with this, really we don't have to force them to the treatment. We have to involve their family and we have to understand their needs. And the other thing that's already been done in Ethiopia is training non-physician providers like mental health practitioners or professionals. So that will help address the need for mental health in Ethiopia and other places. It's the same thing here. So the main takeaway, mental health is central to hospital universal health coverage. So we talked about delirium, the assessment, and how to address or how to prevent, and alcohol withdrawal symptoms management using the CWA. I'm not quite sure if you guys use CWA protocol here, but that is really, really very helpful, and all the management is based on that score. And screening early and act with validated tools, as Dr. Alison mentioned, primary care is the place we can catch early with a person with mental health. So the screening is very important. Build equity into workflows like language, culture, task sharing. This is the references. That's all I have. Thank you.
Thank you, Dr. Abdirahman, for your nice presentation. So now we are going to have a discussions on the presentations. For this reason, I will invite all the presenters to up to the stage, and after that we have a discussion time.
Okay, thank you all for the nice presentations. My name is Asfat. I'm a psychiatrist from the St. Paul's Hospital Medical College, Addis Ababa. So, my question to Dr. Birra is already asked. So, just to summarize, I want you to say how scalable this intervention is, because it addresses a lot of conditions with less options of treatment, so like aggression, self-injurious behaviors, OCD, and PTSD. These are important areas to work on, but I just want to know how scalable this is, and my brother already asked the drawbacks or the adverse effects, the negative adverse effects. So, my question to Dr. Allison is, you've been telling us nicely about stigma, and also about self-stigma. So sometimes I think of self-stigma and how I understand self-stigma sometimes is we stigmatize ourselves after getting the illness because we have been stigmatizing others before getting the illness itself. So it's because we have been stigmatizing other people who have been psychiatric illnesses, and then we feel stigmatizing ourselves when we have it. I think it's a nice message for
The other day, I was reading a quote from a person known as Mel Robbins. Your mental health is everything. Prioritize it. Make the time like your life depends on it, because it does. That's what it says. I'm sure your deliberations were wonderful and effective and successful, and I'm glad to be back again to stand in front of you. In front of these all scholars from different corners of the world, and those of you from other parts of the world, once again, welcome to Ethiopia, the land of origins, the birthplace of coffee Arabica. His Excellency Dr. Tesfaye Kababo, Deputy Head of Oromia Health Bureau and Wing Head of Public Health Emergency Management, Health Research and Laboratory Service, who is also guest of honor of this very closing event. His Excellency Dr. Malkamo Abite, Deputy Director General of the Ethiopian Public Health Institute, Her Excellency Lili Marcos Birra, Founder and Board Chairperson of ALIBIRA Foundation, honorable leaders and employees of Oromia Health Bureau, honorable participants, researchers, facilitators, honorable leaders from various levels, distinguished guests, excellencies, ladies and gentlemen, all protocols observed. Welcome to the closing event of the 3rd Annual International Health Research Conference, organized by Oromia Health Bureau in collaboration with ALIBIRA Foundation here in the capital at Skylight Hotel. Once again, welcome. I would like to directly invite Mr. Birra Foundation from Oromia Health Bureau for a summary of presentations that he will present. Put your hands together for him, please. Dr. Birra Foundation, come to the podium. Thank you.
Thank you very much, the chairpersons. I'm going to present you some of the key summary findings that is going to be present in the last 2 days. So, today is, the Mental Health Day as World Happy Mental Health Day. So, namni fayyaa ta'e har'a ga'umsaa utuu sammuun keenya nagaan taane ta'e iddoo kana dhufuu dandeenyu waan ta'eef baga gammaddanis jechuun barbaada. Jirtu? Eessa jirtu? Kunis seenaa ta'e, baay'ee galatoomaa. So, I just going to present the summary of the findings, which is presented being the last 2 days. As you know, the mental health team is going to present with granting enhancing mental health care equity, the next frontier, the universal health coverage with few thematic areas like mental health systems, the current universal health service coverage, and community driven solutions and the cooperation from the mental health, and the integrated mental health and the physical health care, adolescent health and the addictions, women's and the mental health challenges. These are the few points that is going to be presented in the last few days. So the other thing is psychosocial and the mental health in crisis setting, especially in the IDP setting, and also the digital technologies, for mental health services is some of the few research findings that being presented in the last 2 days. Yeah. So yesterday, the objective of the presentations was being presented by Dr. Tesfaye Kababo, and he highlights some of the key points on mental health services, especially mental health, particularly in Ethiopia, is somewhat overlooked, and make mental health accessible. As you know, the accessibility problem is, somewhat, that's some part of the areas the health service for mental health is not well accessible, so they call for accessible service, equitable and integratable health system, especially for the mental health service. And they also highlight make mental health explore community-driven solutions. Even there are many solutions which may be helps for the mental health problem in our society. So they highlight the importance of the community-driven solutions and integrating mental health with integrating the mental health care service. The other thing is the movement of collaborations, the importance of collaborations. Collaboration is very important in tackling the mental health challenges. The compassion and the commitment is the point is being raised in the objective sessions by Dr. Tesfaye, that finally they call for the tangible to actions. They call for actions even for evidence, the accessibilities, the community-driven solutions, and they finally call for actions. The other thing raised in the yesterday session is on welcoming speech raised by Professor Natsanet, and she highlights mental health is often viewed as the spiritual rather than the medical care. In most part of our communities is taken as the spiritual case rather than the medical issues, and other also highlights no one is free of mental health. Everybody has some part of some problem associated with the mental health, as highlighted. The other thing is they also raised shortage of the manpowers, the health workforce for healthcare persons, especially focusing on the mental health, like the psychiatrists and specialists working on the nurses, and also the health extension workers. The challenges is, there is a problem in these areas. Also, mental health, can be prevented and treated, and it's also can rehabilitated. The other thing, prevention of mental illness can be promoted through health lifestyles, like strong social support and positive child rearing practice. These are some of the points raised by Professor Zanet, and the securing political commitment, strengthening research, fostering shared responsibilities are the few points raised during the welcome speech by the Professor Zanet. So the other thing is noted by the keynote speakers, Professor Mustafa Ibasi, they highlighted the support of research in collecting data to generate evidence-based actions, especially for mental health, and improve the mental health of individuals, communities, and the society through the resilient integration, collaboration, and optimism. And sharing commitment is very important in enhancing the mental health services. And the other thing that I highlight is achieving progressive improvement in mental health through the capacity building for the health professionals, open dialogue, and shared commitment is the point being raised by the Professor Mustafa. These are very important critical mental health service. The other thing raised by Honorary Obalula Gamada, the founder of the Birra Foundation, the highlight that mental health issues, no one has enough knowledge, especially in mental health service, by raising the experience, the lived experience of their own. So there is no established curriculum to educate even about the mental health service in our education system as well. In the ministries, there is limited data related with the mental health services widely in Ethiopia. So they directly noted call for overall survey regarding with the mental health service data as well as the prevalence. The other thing is many children are affected by mental health condition, yet the issues remains widely recognized as raised before. The other thing is addressing mental health issue requires strong leadership and active involvement, particularly the researchers, the policymakers, as well as the service deliverer or the service providers, as well as the community as well. So they need the integrated approach. They need integrated approach to tackle the challenges related with the mental health. The other keynote speakers, Dr. Mehdi Salamo, the WHO representative, she raised, mental health is not a privilege, it's a matter of universal right for human being. And also she reflects about the overall well-being of the communities. Mental health is a foundation and it is the core for the overall well-being of an individual. The other thing is universal health coverage cannot be achieved without ensuring the access to the health or the mental health care service. Without mental health care service, we cannot achieve the overall well-being, the accessibility as well as the health service delivery in other wings. The other thing is mental health is a matter of development. Mental health is not different from the development. So she raised that mental health is parallel with the development of the countries. If we work on mental health, is working as indicates that as working as similar to the development of the nations. And the other thing she raised is about the mental health should be integrated to emergency preparedness response plan, especially in the humanitarian setting where there is a crisis in some parts of our countries and in the region as well. So the other problem she raised is mental health problems are often exacerbated by the natural and man-made disasters as raised. There is a conflict. If there is a conflict between somewhere, there may be aggravation factors for the occurrence of the mental health problem. And if there is a feeling somewhere, there may be aggravates the mental health problem. The other thing she raised, mental health service must be expanded to reach the vulnerable populations like the IDP and the refugee conflicts areas, even the marginalized populations like prisons and so on. So the mental health should be integrated to those services. The other point raised by Dr. Garramu, Luca is Oromia State University President. He highlights mental health is deeply rooted in social, cultural, and political issues. It's not only a single thing. Is integrated in social as well as the cultural and the political issue. And also the strong and responsive system is needed to ensure the mental health and the well-being, and they call for 3 pillars, like access to inclusion for the mental health, and also they call for intervention to structural transformation, especially our structures should enhance the mental health service, and also they raised the evidence to ethics accountabilities. So they are called for these 3 points. So mental health equity is not a box to check. It is a long-term commitment, listening to learn, to redesign our system, our health system. So they raise these points. And also another keynote speaker is Dr. Masai from EPHI, he's Director General. And they raised tackling public health threats through evidence practice is very important. We have to have an evidence to tackle the challenges posed with the mental health problem. The other thing raised by Dr. Masai is during public emergency, coordinate humanitarian assistance, and contribute to the psychosocial support and the mental health care service is very important, as raised by Dr. Masai. And also there is strengthening capacity building and the public health nutrition to promote the mental health and the well-being. This some of the points raised by Professor Dr. Masai. The other thing is the keynote speaker raised by Professor Bork, the AHA Director General. We catch few points to the point is to enhance mental health security service call for all large for complexity of human mental health problem and mental health challenge are emerging issues affecting the equity as well as the accessibility of even the Ethiopians as well as the sub-Saharan African and African countries, including Ethiopia. And also they raised a few questions. How can we address mental health challenges through research and knowledge? So they raised very important questions, especially which is used for researchers, especially in the higher education institutions. And as the researchers, how can we address mental health challenges through the research and innovations and new ideas? The other thing they raised was how can we ensure the research and innovation to translate into the practical solution? We are doing research here and there, but if it is on the shelf, sometimes it's very difficult, it's very common. So they raised how can we translate such type of evidence, how can change, how can we distribute, how can we absorb such type of evidence generated in here and there, especially in higher education institutions as well as other research institutes. And also they call for ensure the most vulnerable populations, including those with mental health issues, benefit from the evidence and the knowledge generated from this conference outreach and beyond the raised points. And we also take an assignment to solve these important questions, and they finally put that to ensure no one left behind, we have to put the mental health as a core for every our service, especially in our health services. Yeah, the keynote speakers noted by Mr. Lady Birra, the founder of the ALIBIRA Foundation, she raised that some part of mental health is somewhat overlooked and misunderstood by our community. So this should be solved with research and as well by the involvement of Bagadas as well as higher thinkers and the community leaders. The other thing is mental health service should be accessible as well as should be compassionate and respect to the dignity of an individual for everybody. So they read very important points. Finally, at the opening speech, Her Excellency Dr. Megles Lava, the Minister of Health, raised very important points related with the mental health. She raised that mental health is the foundation for everything. Mental health is, the foundation for even the other health services. Without pain, we cannot do anything. For example, if our health workers there are mental health problems, like if they are working stress, it's possible to achieve our universal health service coverage as well. So I think it is the foundation for all health service. And they also raise stability families. The mental health is more of competency. It's not a single thing. It's the matter of communities as well as the matter of the families. And also they raised mental health can be elevated through social support and development interactions like ECOP, EDR. They raised also the role of the Bagadas and the thinkers in addition to the clinical services that we have given in our hospital. And the other thing is, they raised, innovation, digitalizing, capacity building are essential for advancing the mental health services. Innovation, digitalization, the core for providing the mental health service. And finally, they call for actions make mental health service accessible and equitable at all levels, including the catastrophic situations wherever there is IDP or a humanitarian setting. The mental health should be one for one of the core competencies. The other important sessions that have been had done yesterday in the panel discussions, these are the panelists and the moderator is Professor Abdallah, and the theme is under current mental health care service, stating Ethiopia's challenges and the opportunities. These are the points being raised. A few points was covered in this session. The point which is raised is the stigma towards the women mental health services. So these are the one of the points. The challenges related with the stigma. Mental health service shall be advocated at all levels, not only at the government level only. It should be advocated at community level as well. The government level is also included in the policy part. So mental health service users' voice shall be included in all activities related to mental health. We have to raise our voice. We have to loud our voice related with the women's mental health challenge they raised during the panel discussion. The other thing is raised is women's mental health is not only about medical service. It is a matter of the equity and the dignity of the human right. They also raise these points. It's very important. The prevalence of substance use disorder in Ethiopia is getting high, with the young age group getting involved more. And the other point is substance use disorder through demand and supply actions of this substance, reductions of this substance, dedicated institutions for substance use disorders. Management should be accessible and decentralized from the higher level to the lower level. The other point related to the panel discussions, mental health stigma is a major bottleneck in service provision as well. And the other point is we have to tackle the stigma related with the people with the mental health. These are some of the points being raised during the panel discussions. These are the overall research findings. There are 19 oral presentations and 9 poster presentations being presented in the last 2 days, focusing on the grand theme, mental health and equity, the next frontier in universal health service care. These are a few PowerPoint, the oral presentations cut during the sessions. I didn't go through all of the presentation due to the time constraints. These are one of the psychological disorders and its associated factors among the DM individuals, the diabetic mellitus. And the other point raised is magnitude of suicidal ideation, attempt, and the associated factors among the HIV populations. These are the research being presented. The point was included in the final points. Orabla, Fayata Devana.
The term Horabula defines many things. It's about health, about well-being, including mental health, about togetherness, about peace, about unity. Horabula, that is how we thank people in Afaromo. Thank you so much, everybody. And put your hands together for Brahanu and Nati once again. Now we're moving to recognize people who made this conference successful. So we're about to conclude it, close it. But your networking, I'm sure, can do more, because these researchers will not be only for shelf purpose. I know you're doing well for the success of the society. Thank you so much indeed. And I would like to call to the podium Gamachu Shumi from Oromia Health Bureau and Sister Saada together here onto the podium, so that we'll start giving certificates for individuals. Thank you so much. And joining us will be His Excellency Dr. Blakamo Abite, Deputy Director General of the Ethiopian Public Health Institute. Put your hands together for him. A round of applause for him, please. Yesterday, Dr. Masal Hainu, head of the was here. Today, the deputy is here. Thank you. And I call recipients of the certificates. First, Dr. Yasin Mohammed. Dr. Yasin Mohammed. Because he is one of the presenters. Mr. Ababa Dukesa Dubiwak, Mr. Andualan Derrasa, Mr. Juan Urtofa, Mr. Makonnen Sahai, oh, you tired? Yeah, a round of applause for these guys because they presented good things on this very topic. Thank you. Thank you. Mr. Zakir Abdu, Mr. Zakir Abdu, Mr. Adisalam Welke Dapsash, Dr. Benti Galata Abuli, Mr. Galata Aneko Dube, Mr. Getacho Kabeda Hailu, Mr. Tashoma Guta, Mr. Salam Seifa Alam, Mr. Yaro Nava, Mr. Hepaye Mokona, Mr. Shagai Schultz, Mr. Nagasa Dibna,
Anwar, suto.
Professor Zoe Burhanu, Mr. Shimelis Birma, Dr. Gali Huntuma, Dr. Hatamu Makonnen, Mr. Fulla Atomsa, Mr. Fulla Atomsa Gaddafa, Dr. Daraja Chala Dirriba, Mr. Bashir Mamiyo, Mr. Ababa Tolera Dirriba, Mr. Ahmed Jabal, and Mr. Emmanuel Adunya. Congratulations for that recognition that you got. Thank you. Dr. Malkamu Gatuma. Board of Deputies in the YouTube, what is it? I would like to call upon Sister hands together, please. A round of applause. She will hand over certificate to panelists who were on this very stage yesterday. Professor Salomon Tafara, Professor Solomon. Let me move. Dr. Davda Safa. Mrs. Elaine Muscano. Dr. Alison Johansson. Dr. Alison Johansson. Next, Dr. Naomi Abdurrahman. Dr. Horace Sediso. Mr. Zagaye Yohannes. Mr. Zagaye Yohannes. Dr. Birra Taha. Dr. Birra Taha. Professor Talaka Azela, Professor. Mrs. Agitu Tadesa, Mrs. Agitu Tadesa. And finally, Dr. Lulu Benya. No, but Dr. Lulu Bakana, sorry. If you're not around, thank you so much, Sister Tigist, the very dedicated of Roma Bureau. Put your hands together once again for Sister Tigist. That I always say, if you educate a man, you educate only one person. If you educate a woman, you educate the whole family. That's what I said. Let's move to the third and the final part of this very award. And I would ask His Excellency Dr. Tasfai Kaburu, Deputy Head of our Health Bureau, to join us now on this very podium. And this topic is relevant to Dr. Tasfai. That's why there is a thing, and that's what it is for. And the first recipient of this certificate will be Professor Atale Allen. Professor Atale Allen, the facilitator, the moderator of yesterday. And that's it. Even in his absence, we recognize. Dr. Adam Ismail. Dr. Adam Ismail. Dr. Melissa Negusi. Dr. Melissa Negusi. Dr. Abdi Pulcha. Dr. Abdi Pulcha. Mr. Ephraim Manekul. Mr. Ephraim Manekul. Dr. Eshetu Ejeta. Dr. Eshetu Ejeta. Dr. Zainab Benya. Dr. Zainab Benya. A little bit higher for educated women. That's why. A round of applause, please. Mr. Abasa Gobana.
ቆይ ከሱ ቀጥሎ እንትን ስላቀሳይ
Dr. Abdi Bacha, not Bulcha. In journalism, one of the crimes is missing names. So, thank you. Thank you. Mr. Burhanu Kanati from World Health Bureau, the presenter, the summer presenter. Mr. Gitar Fatansa. Mr. Gitar Fatansa. Miss Firmaya Bogale. Miss Firmaya Bogale. Dube Firmaya Bogale. No. We move on to individuals who are on public lecture. Dr. Abdurrahman Rone. Dr. Jane Marie. Dr. Jane Marie. Dr. Mustafa Alabsi. Dr. Adil Katabai. Dr. Adil Katabai. Dr. Chai Law. Dr. Chai Law. Dr. Naomi Abdurrahman. Dr. Birra Taha. And finally, Dr. Alison Johnson. Professor Afot Tamu, of course, in the final recipient of the certificate here. Professor Afork, Mr. Afork Tamu. Mr. If I do what I said Professor, you can try. I said Mr. You can. Thank you so much. Thank you. Is it even fun as it's a new system? So Adana is Dr. Tasmaya Sulfan, and it took us a day. We do have 5 minutes to be on this stage. By the way, I enjoyed the topic. Despite my absence in the syndicates, I got something. At least a journalist should know something about everything. So I learned a lot from you guys. Now I would like to invite to the podium His Excellency Dr. Malakamo Abdi, the Deputy Director General of the Ethiopian Public Health Institute, for some messages to be addressed to the very participants. Thank you.
Good afternoon. Good afternoon, my country. Good afternoon. Yes, thank you so much. Excellencies, Dr. Ismail and Sister Tigist, Deputy Oromia Bureau Heads, and Mr. Sli, the Chair of the ALIBIRA Foundation, and the Founder, invited guests and all protocols observed. It is really a pleasure for me to be part of this session today. I'll be very brief as most of the discussions was fruitful in production that I've seen, but I'll be very brief and I'll pick on some points. What I want to express here is what we are learning from the sessions like this. One thing is where our expectation and what we want to do here is to have such kind of regions who has the capacity of having such kind of sessions. What we can do, one of the priorities that we are going to do is to strengthen the capacity of the regions. So having such kind of conferences by the ownership of the regions, the ownership of the research and the different departments, one of the commendable things that we're taking as an example for other regions to learn. And the second point is, unless partnership is here, we can't make it. So I saw there are different partners from universities, from international organizations, from foreign universities, from other regions, from partners. So this is one of the critical points that we are going to learn from this scientific conference. That everybody is coming at the front, everybody is coming on the table to deal on the priorities that we have, the problems that were on the table. And the third point that I'm very much impressed about is having the thematic area on this mental health activities, as it is saying enhancing mental health care and equity. One thing is to enhance the care, and the other is equity has to be at the center. We had a very nice conference for the past few days here at Skylight in parallel with this program, and I was one of the panelists there. And one of the main topics that we're dealing about is how we are going to make our primary health care system resilient. So resilience starts in the community, and resilience is in the community. So to have a resilient community, one of the pillars has to be this mental health activities. So what we have learned from this session is these mental health activities has to be integrated with our overall interventions. It has to be one pillar. For this to enhance it, what we are doing at the PHI is now, one, we have integrated it with our structures. So it is becoming one of the structures that we have, these mental health and psychosocial support structures in our APHI structure. The other thing is having a proper data is one of the points which was raised by the summary. So for this data to be coming in a regular, in a routine way, so we are now making indicators to be a part of our surveillance reporting, our surveillance data, which we are going to announce in a short period of time, so that we are planning to integrate it in our already existing system. So this is a critical point which has been raised at a critical time, and we from APHI, we from the federal government, as it has been manifested and that has been said by the commitment of the leaders by their opening speech yesterday. So we have the commitment to work in this line. And the final point I want to raise is the foundations like this ALIBIRA Foundation, we have done a very nice job by sponsoring, by working closely with the regions. So this is appreciated, and this is going to be an example for others. So the charity for the people means reaching at the critical point, at the critical time. We really appreciate it from our side as well. Thank you so much. At last, I want to say that I'm very much happy, and from APHI, we all are committed to work with you. Thank you so much.
Thank you, Dr. Malcolm, the Deputy Director General of Ethiopia Public Health Institute, for that wonderful message in which he calls on the public for collaboration, togetherness. And the next message will be delivered by Her Excellency, as a matter of document. Her name is Lily Marcos Birra. As a Mogasa name, Lily Birra, founder and
board chairperson of ALIBIRA Foundation. Thank you.
I have myself mental issue. When I face a lot of people, I get nervous. So I have to apologize. I have to write it, or otherwise I will freeze. So anyway, Excellencies, Dr. Tesfaye, Deputy Heads, Dr. Tesfaye, Dr. Tigges, Dr. Malcamo, all protocol observed. Akan jertan, bagarabin at sinugayan. I am speechless for how our event turned out. This is just the beginning. We created a big awareness and enthusiasm at home and abroad. We should be very proud. You should be very proud of yourselves. I am already receiving messages everywhere on how they can participate next time. Oromia Health Bureau, we cannot thank you enough for taking ALIBIRA Foundation, a very small or a baby organization, under your wings. I truly believe that the sky is the limit going forward. I personally thank Professor Nathanet, Dr. Tesfaye, and the whole team for your patience, wisdom, and understanding in every step of the way. It wasn't easy, I understand. Whatever success we created today belongs to you. Thank you so much. You are an amazing group, so professional, dedicated, and sincere. You are all, to the ALIBIRA Foundation team, you are already a family to me. Let us continue paving the way for more successful events like this. To the participants, we trust you all came from different places and everywhere. We trust in you to go out there and spread the word. Start to apply what you have learned, and do not be afraid to reach out when you face challenges. Our team, ALIBIRA Foundation, is at your disposal. We look forward to work with you in the future. We cannot do it alone. Once again, on behalf of ALIBIRA Foundation, I thank you all for coming. From now on, we are a big family. From now on, I will be honored if you call me Habu Lili, like everybody does. Baye Galatoma Olfada.
Yeah, the name of that great person would always live on. ALIBIRA Ali Muhammad Musa, the legendary, the king, the actor, the composer, and polyglot, who, by the way, speaks 8 languages. Amazing. Thanks so much indeed. Lili Marbasura. And I would like to invite His Excellency Dr. Tesfaye Kabogo, Deputy Head of Oromia Health Bureau, for closing remark. Put your hands together for him, please. Thank you.
Kam jirtu nagaa jirtu waan baay'ee jedhuun qabu Dr. Malkaamuu fi haati keenya Lilli Birraa waan guddaan nuun jedhaniitiin jiru isin galateeffachuuf qofaaf iddoo kanatti kan hamba jechuudha. Your Excellency Dr. Malkaamuu Abbitee, Deputy General Director of Ethiopian Public Health Institute, our mother Lilli Birraa, the chairperson of ALIBIRA Foundation and the founder, all the team from Minnesota University, all panelists, all moderators, presenters, all our partners, especially those who have been engaged in as a collaborator for ALIBIRA Foundation, and the only private organization which supports the Regional Health Bureau is the Lando and the Mindri Company. Thank you for your contribution. Thank you for your time and the technical expertise, all of you. Galatoma, Ulfata, one listen of Gotan Salpanity, one good data. The city at the Kesati, one good data, one good data again, one again can more Malgona. This is not university or other foreign, but it is an institution and implementers. Partially is a policymaker, but most of our job is implementing the idea, implementing the policy. So how can we implement the research output? How can we integrate to our policy? How do we integrate to the health system? Ableen fayyaa keenya maal asirraa baranna? Keessumaa hospitaalonni soddomni siwaamne Universitiin torban as jirtan akkuma kana geggeessonni magaalaa fi godina maal asirraa baranne? Maal asirraa fudhannee hojiirra oolchuu dandeenya? Biiroon fayyaa asirraa fudhatee maal hojiirra oolchuu danda'a? Qaawwa akkamii qabna? Qaawwa qabnu sana immoo maaliin duuchuu dandeenya? Yoo riisarchii dhiyeessuu ta'e, konferaansii yoo ta'e, yuunivarsiitiin baay'een akka kanatti hin dhiyeessu. Fooremii baay'een hin gaggeeffamu, workshooppii gurguddaan hin gaggeeffamu. Garuu hawaasa keenya bira gahuudhaaf riisarchii outpuutii kanarraa maal fayyadamna gaaffii guddaan. Warri sagantaarra jiru maalirraa fayyadamee gara hojiitti jijjiira kan jedhu assaayimentii keenya jechuudha. Poolisiidhaaf galtee ta'uu danda'a. Yeroo dhukkubsataa tokkoon tokko isaa yaallu galtee ta'uu danda'a. Ekspiriyaansii Minnesota University irraa arganne tooppikii adda addaa irratti nu leenjisaa turan sun infraastiraakchariin keenya nu eeyyamuu dhiisuu danda'a. Garuu immoo kompaashineet taaneetoo lammii keenya dhukkubsataa tokkoon nu bira dhufu ittiin deeggaruu dandeenyaadha. Keessumaa warri godinaa magaalaa fi hospitaala irraa dhuftan yoo inni kun hojiirra ooluu danda'e, yoo inni kun gara hojiitti jijjiirame gammachuun keenya guddaadha jechuudha. Kaayyoon konferaansii kanaas galma ga'e jechuudha. Kaayyoon ALIBIRA Foundationis galma ga'e jechuudha. Oromoof qabsaa'aa turanii, Oromoof sirbaa turanii, namni lama namni sadii faawundeeshinii kana keessa jiraatu iyyuu malee umurii isaanii guutuu kan dabarsan, kan qabsaa'an Oromoon akka baratu, Oromoon akka tokko ta'u, Oromoon akka biyya isaa jaalatu, akka biyya isaa ijaaru, akka duubatti nafne, sirna isaa akka qabatu, aadaa isaatiin akka guddatu, uummata nu barsiisan, uummata fuulduratti ceesisan, nu tarkaanfachiisan jechuudha. Har'a namoonni lama sadii gaggeessuu danda'u. Kanaaf mul'ata isaan qabatanii turan kana akkamitti dhalootatti dabarsinaa, fayyaa keessatti maal irraa fudhannaa waan guddaadha jechuudha. Isaanis waa hunda irratti miti kan hojjetan. Dargaggeeyyiin keenya yeroo ammaa suusiin qabamanii rakkoo adda addaa keessa jiran, araada adda addaa keessa jiran akkamiin keessaa baasuu dandeenya? Kanaaf godinni keenya, magaalli, hospitaalonni keenya, yuunivarsiitiin naannoo Oromiyaa keessa jiru immoo dhugumayyuu addikshiniidhaan uummata keenya rakkataa jiru, dargaggeeyyii rakkataa jiru, hojii dhabaa rakkataa jiru, akkamitti gara jireenya nagaatti finna? Gara sammuu qajeelaatti finna kan jennu waan baay'ee irraa arganne jennee yaadna. Keessumaa kaleessa paanel diskeshinii gubbaa irratti waan guddaa irraa argaa turre. Sabstaans addikshinii caatii irratti nuti jennu caala qorichoota namni meeqa miidhamaa akka ture ragaadhaan nutti agarsiisaa turanii jechuudha. Paanel diskeshinii kaleessa irratti. Kanaaf godinoonni keenyaaf magaalonni keenya, hospitaalonni keenya keessumaa aanaa warri deeggarru, ganda warri deeggarru akkamitti dargaggoota keenya achi keessaa baasna kan jedhu yoo hojiirra oolchuu dandeenye, yoo jabeessine saayikaatirii, OPD moggaatti ba'eetoo jiru yookiin OPD eeggatee hojjetu, OPD gaarii banuufi yoo dandeenye, qoricha inni barbaadu bituufi yoo dandeenye, gaayidlaayiniidhaan akka inni hojjetu leenjii kennuufi yoo dandeenye, onnachiisuu yoo dandeenye, riisarchiin keenya kun galma ga'ee jechuu dandeenya jechuudha. Health keeriin keenya hin guddisna, enhancing mental health jennee kan qabanne, keerii qabanne kana universal health coverage dhugoomsina. Fuuldura taammatu kan jennu kuni yoo asii galleetoo kana gochuu dandeenya jechuudha. Kanaaf akka biiroo fayyaatti ergaan koo inni guddaan keessumaa hospitaalaa fi godina magaalaa warri dhuftanii gara hojiitti jijjiirtanii tajaajilli kun banamuu yoo danda'e gammachuu keenya waan ta'eef yoo kana nu gootan galma geenya jennaa, yoo kun hojiirra hin oolle ta'e immoo walgahii akkasumaanii ta'a. Sababii ta'eef ergaa keenya akka qabattan siniin jedha. Kanatti dabaluun warri nu deeggartan silas dubbadheen jira Gilaandoo Mandirii akkuma kana immoo ALIBIRA bukkee warri dhaabbattan akka Biraayitee maqaa dhaabbilee baay'eetu jira Siinqee Baank, Oromiyaa Baank, Raamis Baank dhaabbileen gara biroos baay'eetu jira kan isaan deeggaran bukleetii keenya abstiraaktii keenya irraa ilaaluu dandeessu bukkee dhaabbattanii nuun fayyaa irra deeggaruu duwwaa odoo hin taane boruuf taanillee hojii dhaabbanni ALIBIRA Foundationii deeggaru keessatti akka deeggartan ergaa koo dabarsaa qe'ee nagaatti galaa rabbiin sin faana haa ta'u ulfaadhaa galatoomaa isiniin jedha.